call upon our impeccable speaker for the session, Journey of Medical Students, Dr. M. Satyadev, Professor and HOD, General Surgeon at Father Colombo Institute of Medical Sciences.
Dr. Satyadev was born in Dehradun, UP, done his MBBS in Kurnool Medical College, MS General Surgery from AIDS, Delhi. Joined as Assistant Professor of Surgery in MGM Hospital in 1983. Later became Professor and HOD of Surgery from 2000 to 2013. Served as a superintendent in 2011 to 2012 and Principal from 2012 to 2013. Retired as Principal from Kakatiya Medical College from 2013. Served as Professor and HOD of Surgery in Institute of Medical Sciences from 2013 to 2023. Now Professor and HOD in Father Colombo Institute of Medical Sciences.
Good morning, everybody. It's a wonderful occasion today. A conference of the medical and the pharmaceutical. And I thought, I think it's a very interesting topic, but boring you with too many advisors and or servants. Just a small pet talk, my journey into MBBS, because that was interesting. And I thought I'll make it into a small story format so that you will not get bored listening to it. So here my father was audit officer in the defense account, so he was central audit officer. So I was never in one school at any time. So it was different places, Pune, Bombay, at those days it was called Bombay, now it's called Mumbai. So different places at different places and different, in within a year it's 6 months in one school, 6 months in another school was my usual way. So the first scenario, he was a government officer, so we had scenario start with my 11th class. See, now we have a 10th class, it is class after 10th class. So this was in Bombay, and the school is the Regulation High School in Srinagar, Kolivada, and we were staying in a colony there. We had a beautiful house, actually it was allotted to quarters with the CGH dispensary was there inside. So fine, that was that. And so it was my class 11th class examinations. And then we had a neighbor, the name who was also Telugu boy, Telugu, and there was a guy, a friend of mine called Subramanian. He once came and told me, okay, you are appearing for exam. It is not from my same school. We are appearing for the same examination, but I am not going to read for the examination, and I am going to appear and going to pass the examination. I said, I don't take it science. I said, no. It's a crucial examination. I don't think I should take that challenge like that. Let me do it my way, you do your job. So I worked really hard, worked hard. And then I scored very good marks. I think I got distinction almost in all subjects except in Hindi. And he passed, but he just passed. So later on, I think in life, he just later on is short. So why I have stressed on this is the value of hard work. Hard work always pays. Remember that. You may not have to be very intelligent. You don't have to be very intelligent, but your hard work will always compensate. And there is no substitute for hard work. The next scenario for me was college. The Ramnath Royal College in Mathematics, away from my place. And there I joined my intermediate, the second year of biology. In those days, the first year was with all the subjects. The second year, first year was smooth, wonderful, fine. Second year was also smooth. Then one day, there was a CGH dispensary. I went to the dispensary. There were about 4 doctors there. Okay? And they just on a casual talk, they asked me, what are you doing? I said, I'm doing my intermediate. What do you want to do? They said, I want to become a doctor. That's my father's ambition. I really didn't have many goals at that time. Because probably very immature mind it was. What do you want to be? I said, doctor. अरे तुम डॉक्टर बनना चाहते हो क्यों जी? Don't. It's a horrible profession. Don't take at all the profession. See, we are suffering. That influenced me so much. I stopped reading. I became that like a Subramanian in 10th class who challenged me. So it was that I didn't have a father to work. It just totally turned me off from my aim or whatever I wanted to become. I didn't know what to become. I passed the examination. I passed. But then I missed out on my MBBS seat with just 1 mark. 1 mark. In those days, we didn't have entrance examinations. So I missed out by just 1 mark. You know what? My father was very upset. He was devastated. And then I didn't know what I was doing. I was roaming on the roads of Bombay. What to do? Then, based on my first year, I thought I could write an IIT. Because I was good at physics. And I went to solo thing. So I wrote. It was also for preparation I wrote. I got a seat. But I didn't get in any very prestigious institution. I got it in a place like IIT, PHIT, Banaras Hindu University. So, okay. My uncle and aunt were there at a place called Gurdwara, which is near Vijayawada. Now, since Varanasi is a very pilgrimage place, they said, okay. So, Karyam, Nikaryam, Vidari is the person, we got us from. So, we went there. Okay, I didn't join, I don't remember exactly. Then I really didn't know what to do. See, my aim, there was no goal, there was no objective. I wanted to fulfill my father's ambition, but then it was all complete, dreams were all shattered. So then, from there, I came to know that was Andhra Pradesh was conducting an entrance examination in MBBS, and there was a chance that I could appear. Okay, fine. So the application form was with my cousin at Gudivada. Gudivada is a place which is 1 hour journey from Vijayawada. So then I had to take an application form. I think on one of the last days of application or something like that, I came to know that. So I traveled from there to Vijayawada in a train. And to my great surprise, I had to go from there to Gudivada to take an application form from him. But then what happened was, at the time of entry of the train into the railway station, to my great surprise, I saw my cousin entering, who had come from Gudivada to Vijayawada, carrying an application form. What a coincidence. I had to go to Vijayawada, from there Vijayawada go. He didn't know that I was coming. I didn't know that he was coming. It was a coincidence. In the railway station, of all the places he was coming to the railway station to post the application to me. Well, I thought there is something destiny. I thought destiny is there for me, and I am destined to become a doctor. Nothing is going to stop me from becoming a doctor. So I wrote that the first entrance examination of Andhra Pradesh, we were the first people to appear for the entrance examination, and I got a seat in Kannur Medical College. And my journey after that was relatively smooth. So the lesson from this, what we learn is that hard work, there is no substitute for hard work. And we had our batch was also a great batch. We were all very good students. Our batch, I think, probably was considered as one of the best batches that ever emerged from Kannur Medical College. And we had stalwarts in my batch. The present AIG chairman, Dr. Nageshwar Reddy is my classmate. Okay, and then we had Dr. Jagannath also, who is the surgeon for Amitabh Bachchan. And then we had we were also good. We were also equally good, quite good. Okay, but some had excellent later on in lives. Okay, like that. In this thing, I don't think we should get very worried. What I want to convey to the students is not to get too worried that we have not become Nageshwar Reddy's too many stalwarts. There is one quotation which I'll just read out. The quotation is from a great physician called by name Sir Robert Hutchinson. I think he was the author of the book Clinical Results in Medicine, which we read as undergraduate students. He said, let me tell you to not aim too high. Okay? The prices that are offered in our profession are only for the few, and they do not always bring happiness when gained. If you earn enough for your needs, okay, and you are able to put a little aside for your old age, and you get the esteem at the same time, the esteem of your colleagues. You get your esteem of your colleagues only when you show skill, your efficiency, and your knowledge, and your sincerity and honesty in your profession. And the affection of your people, of your patients. Your patient's affection you get only when you show empathy to the patient. And empathy to the patient is very important. It is irrespective whether that's doctors or others. In this example, I will give an example about empathy. A few years back, my cousin, he died of lung cancer. He died of lung cancer because he was a smoker. He died of lung cancer. He was offered chemotherapy at one of the corporate hospitals of Hyderabad. Okay? And then one day, he was given chemotherapy, was admitted for chemotherapy. The next day, the medical oncologist, he came to see him. He said, "Are you That is the talk of a patient to a patient who is already depressed with cancer. He knows he is going to die of cancer. See, if somebody is going to die, nobody knows at the time of death, you won't know anything. Your brain is not going to function, you are going to die. But a talk to a patient from a doctor, do you know who is supposed to, even if a patient is going to die, one word of sympathy and empathy is so important. So I took it up very seriously. I came to know this. He happens to be my uncle, one of my uncles, and he told this is how they were talking, and he's also very deep, he's crying. So I took it up this very seriously. I talked to the director also. This is not the way. See, ethics are very important. When you deal with a patient, you have to be very sympathetic to the patient. You may die, he may die, it doesn't matter if he dies. But it's your very duty to talk nice to him. The patient, you have become pessimistic and you have taken as if he is going to die. No, this is not attitude. This is the attitude which we should not have. Patients are the most important people for us. Okay, you keep your patient in front of you and everything should go up with you. Everything should be patient concern. If the patient is not able to pay you much, it is your duty to take care of the patient. It doesn't matter. You really need some amount. Maybe you will not, just for the sake that you may not be able to afford you, or you see, I find this culture of this apathy towards patient in corporate sectors. I have seen this in one of the places also. I will not name the corporate hospitals, but they treat patients many times as objects from where they can get some money. Okay, this is why I'm stressing on this is the empathy, the sympathy that you have to the patients is very important. Okay, and then also, you feel your failures are always a stepping stones to success. Thomas Edison said that if there are many failures, before failures, you are always reaching the success. And many people who are failures never realize that they are very close to success before they give up. So never give up in life. Have belief in yourself. Have belief in yourself. Okay? And work hard. Be sincere to your profession. There was a great teacher about Dr. C.V. in BPS, and he said, take care of your patients, take care of your students. Everything else will take care of you. Okay? It's very true. It's very true. So be sincere to yourself, be sincere to your patients, be sincere to your profession. Everything else will not matter. Everything else will take care of you. Okay? So with this, and also I'd like to have a talk on what's called a collaboration between a collaboration with the physician and the pharmacy people. See, the pharmacy, you people know much more about medicines, their effects and side effects than us. You may be able to diagnose. So it is very important that doctors and pharmacy people, they collaborate each other for the care of the patient. It's very important that pharmacists should also warn the doctor if he's writing some prescription which may harm the patient. So it is not just follow the prescription written by the doctor. You should also be able to discern whether is it okay or not, and be able to tell, because the doctor may be unaware. You can't expect him to know everything. You know, that pharmacy people should also do this. So it should be hand in hand, work hand in hand with your doctors, and for deliver ultimately the patient is very important. Patient and care, patient care is the most important. I thought a small pep talk for you people. I don't want to waste my time too much on other things, and I wish all of you the best wishes, okay, and then in your careers. And this maybe I'll just add one line on, since the young people are all here, a small point on investments of great I think to know, small one line, just may not be very, it may not be this particular talk, but recently I started looking at stock markets into lectures, free lectures of stock market. They don't look at anything, but one line that I've always come across, and that is the name of Warren Buffett. I think one advice from him is, as your young people, always, and I think that which Robert Hutchinson's statement, which says that you should put ahead, keep for your needs and all. So what he said was, if you earn 1 rupee, 20 paisa, you save it. As a saving, you forget that 20 paisa. The remaining 80 paisa, 20 paisa you invest, which may fetch you or may not fetch you things. 20 paisa you keep it for your travel, keep it for going out and enjoy, and remaining 40 paisa you will spend. Okay? I think that is a small investment advice from my side to your side. So, thank you very much for my small talk. I have talked about so many people, and welcome lessons to the point. My immediate journey was this, and afterwards I just got the point that my journey beyond it was not much a problem. So I think I can conclude with this, and then we can go ahead with your next programs. Thank you very much.
Any questions building up regarding this session, or anyone from the audience can ask to the sir. If anyone are having any questions, you can ask to the sir. Yeah, if anyone has any questions, you can ask. Okay, I hope anyone doesn't have any questions. Thank you, sir, for your thought-provoking discourse and for taking over the scientific session by your gracious seminar.
Further, going by our tradition to felicitate our beloved guest, we kindly request him to cordially accept our gratitude in this forum.
Let us start with Dr. M. Satyadev, speaker for the session. We request all the dignitaries of the dais to come forward and felicitate, sir. I request Devi Srinivas sir and Manish Kumar sir, HOD of Balaji Institute of Technological Sciences, onto the dais. Give a big round of applause.
Look at that. One more.
చర్చ అయితే బయటకు పోయింది మనలో అయితే ఇగో సాయి క్లాస్ వచ్చేసి బ్యాగ్ ఉంది మర్చిపోయాను మర్చిపోద్దాను మర్చిపోయాను కరెక్ట్ పర్ఫెక్ట్ చెప్తున్నాను సాయి
ఇట్లనే ఇట్లా మంచిగా సెట్ చేసినాక అలాగే పోతే చెయ్యి యాక్షన్ దారిలో లేకుండా లైట్ మంచిగా సెట్ చేసిన మంచి పెట్టుకుంటాట
చెప్పాలి గమ్మది చెప్తారా
ఏం మాట్లాడాలి
కొంచెం ఫ్రంట్కి రండి సార్. సార్ 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 ముందుకు రండి. బ్యాక్ లైట్ వస్తుంది, ముందుకు రండి. అక్కడ కూర్చోండి. యా సార్, థ్యాంక్ యూ.
ఓకే ఓకే సార్. సార్ సార్ ఓకే వెళ్ళిపోయా సార్. థ్యాంక్ యూ. Okay. Okay, sir. ఏమేంచిందా? ఏం చెప్పినా నీకు? ఆడ కింద కనపడతలేదా? తీసి బయట వేసినా దొరుకుతలేదంటారా? బయట తీసుకురా, బయటకు రా. ఏం చేస్తా? అవసరం అయితే ఒక సైడ్ తీసుకొని ఒక సైడ్ కొండు, ఒక మిడిల్లో ఉండవు. నాకు డిస్టర్బెన్స్ అయితే మరి చెప్తాను.
Privileged to introduce Dr. Bhagirath sir, who has completed his MBBS from Guntur Medical College and MD in General Medicine from Andhra Medical College, Visakhapatnam, and he stood first rank in cardiology in PG entrance exam. And he also completed BA cardiology from Usmania Medical College, and is the founder of Bhagirath Cardiac Center in Warangal, and presently is working as HOD of Cardiology, Medicare Hospital, and consultant at Yashoda Hospital, Sumatra. So I welcome Bhagirath sir to deliver his speech and enlighten the gathering. Thank you.
Good morning, everyone. I am honored to start this wonderful conference as the first lecture, and I really thank Kala Padmavati College Management, Dr. Varun sir, Dr. Venkateshwar sir, and Vagdevi College Principal, Avenida Solutions, Dr. Karthik is my long-time friend, and Medical General Hospital Management, Dr. Chinnapreddy sir, Dr. Sandhya Rani ma'am, and all other dignitaries on the dais. So we are going to start the lecture with an important topic, which is number one killer of the world, that is heart failure. So by the end of the talk, we want to address the few challenges that we can manage in a simpler way for the heart failure, which is the dangerous disease in the whole world, especially in India. Next slide, please. So, as the tagline mentioned, the underprescription, underdosing, and non-adherence to important medications that are already available is the most common cause for not decreasing the deaths in the country. So this slide is showing that all over the world, almost like 6 crore people die every year because of heart attacks, and that number is increasing. Why? Because the age of the population is increasing, and there are risk factors that are increasing like hypertension, diabetes, and coronary artery disease. And even after heart attack, we are doing more number of procedures like stenting and bypass that are also increasing the number of heart failures that are present over the world. So, as I already mentioned, heart failure is the most common cause for death in the world, even more than cancer, accidents, and suicides. So, this slide shows that it's not just cardiovascular disease, but there are so many other causes for heart failure, like end-stage diabetes, end-stage hypertension, CKD, and also alcohol. Alcohol is also one of the most common cause for heart failure in India, causing alcoholic dilated cardiomyopathy. Other causes like genetic causes are also there, which causes cardiomyopathies, and that are all accumulated as end-stage heart failure in the world. This slide is showing that the deaths that are happening in the heart failure is more than 50% by the end of 5 years. That too, 4 to 6% within first admission. Patients die with heart failure, and by the end of 3 months, almost 30% of the patients die with heart failure. And by the end of 5 years, 50% are dying. This is a huge burden, huge prevalence that should be tackled, and most of the studies that are present in the down part of the slide, like Ascent Heart Failure, Atomic AHF trial, all the trials are showing that the number of deaths are very high in heart failure. Once it is diagnosed, the mortality is almost 50% by the end of 5 years. So, what are the causes for prevalence of heart failure in India is there are at least 1 crore people, 1 crore of population are with heart failure in India, and heart failure in India presents with post-admission mortality 20 to 30%. India has relatively younger population. One of the reasons is, like as I already mentioned, addiction with alcohol and infectious causes, viral myocarditis and all, and poor pregnancy care like postpartum cardiomyopathy. All these are all causes of heart failure. So India has relatively younger population of heart failure, and 1 in 5 heart failure patients die within 1 year of diagnosis, and 3 out of 5 are dying within 5 years of diagnosis. Incidence of diabetes is almost 50% of the heart failure patients are having diabetes that can be tackled, and hypertension is also one of the common causes of heart failure. This study is showing that there are so many newer drugs that has come into the market that are really helping us out in decreasing the mortality and morbidity. But yet, not even 30% of the population are on guideline-directed medical therapy. There are many reasons for patients not kept on guideline all the 4 drugs. That can be due to doctor inertia or non-affordability or non-adherence and all. So this slide is showing that not even 50% of the patients are present on or given all the 4 important drugs like ARBs or beta blockers, SGLT2 inhibitors, mineralocorticoid receptor antagonists. These are the 4 pillars of heart failure management, but not even 50% or given all the guideline directed medical therapy. So this slide is also showing not even 25% are receiving guideline directed medical therapy, and the right side of the slide is showing that if the patients are on guideline directed medical therapy, the mortality can reduce by half, and it is significant p-value. The same is repeated, and the mortality is increasing for every admission. So once the patients are not on guideline directed medical therapy and the patient admits in a hospital with acute decompensation heart failure, that is congested lungs, then the mortality increases. So to decrease the number of hospital admissions, all the patients should be kept on guideline directed medical therapy. That should be started with all the 4 pillars. That is ARNIs. When intolerant to ARNIs, they can be kept on AC inhibitors or ARTs. And the other one is beta blockers. Next is SGLT2 inhibitors. Fourth is mineralocorticoid receptor antagonists. If the patients are combined with all the 4 drugs, then definitely mortality can increase. And especially in those patients with heart failure with reduced ejection fraction, all these 4 drugs comes under class 1 indication. So what are all the challenges in the management of heart failure is like, we are unable to procure data, especially in our country. Because of lack of data, we are unable to force the doctors nor medical staff to start all the patients on guideline directed medical therapy. So one is lack of data, and still there is persistence of rheumatic heart disease. So overcrowdedness is one of the risk factors for rheumatic heart disease, and that still is prevalent. So we come across most of the patients with chronic rheumatic heart disease, mitral stenosis and aortic stenosis, which can increase the heart failure prevalence. The third important cause is like untreated congenital heart disease. Still we, at the age of 30, 40, still we recognize so many patients with atrial septal defects, ventricular septal defects, that are again leading up landing of the patient in right-sided heart failure and all. There are so much of treatment facilities that are available for congenital heart disease like device closures and all. Once the patients get treated at the very young age, these patients landing up on heart failure will decrease. So untreated congenital heart disease are also increasing the number of heart failures in the country. And of course, coronary artery disease is increasing because of sedentary lifestyle and other lifestyle, bad lifestyle, diabetes, hypertension, chronic disease. All these risk factors increase the prevalence of heart failure, especially in India. And iron deficiency anemia is also highly prevalent in this country, which is again causing heart failure and exacerbating the symptoms of heart failure. And even though the patients are getting ST elevated MI, there is inadequate reperfusion because of lack of cath lab facilities and all in various districts or remote places. Those patients are landing up in ischemic cardiomyopathy, suboptimal guideline directed medical therapy, poor follow. Once the patient is diagnosed with heart failure, and we initiate the drugs, we are unable to uptitrate the drugs to get the maximal benefits because of lack of follow. And even the patients, because of the cost and all, there is poor drug adherence. There is gap in evidence for device therapy. There are so many newer device therapy that has come for treating heart failure, like cardiac resynchronization therapy, pulmonary vein isolation for atrial fibrillation and all. But still they are underutilized because of there is some gaps and cost issues. And underuse of mechanical circulatory support devices, heart transplants, IABs and all, poor financial incentives and lack of even cardiac rehabilitation will also definitely help in decreasing the mortality of heart failure that is not widely available in the country. All these challenges are making us difficult in managing heart failure. So to summarize, like the risk factors are increasing, coronary artery disease, diabetes and hypertension are increasing, and medical treatment, even though it is the cornerstone, it is underutilized, under prescription, because all the 4 drugs are not started simultaneously, and under dosing, they start with very low dose. Most of the patients, uptitration is not done, and non-adherence, supportive care and palliative care, cardiac rehabilitation, even though definitely has mortality benefit, it is not used, and sometimes preventing the risk factors is also not done properly. Lifestyle management is also not done properly. Simple weight loss for obstructive sleep apnea and hypertension and diabetes can decrease the risk factor burden, but still that is not done properly in our country. So all the latest guidelines tell that ARNIs, beta blockers, mineralocorticoid receptor antagonists, SGLT2 inhibitors, when given simultaneously rather than sequentially, will definitely decrease the heart failure. So it is now quadruple instead of triple therapy. And patient profiling. So doing 2D echo and all will give us the profile of the patient. And genetic profile also can be done to look what kind of cardiomyopathy the patient is having. Once the patient profiling is done, starting them on all guideline-directed medical therapy will definitely decrease the heart failure burden. Why there is some clinical inertia from the doctors? Because doctors are not uptitrating. Why they feel that the patient is stable on the current therapy. So what happens with uptitration or optimal medical management is ejection fraction increases rather than if it is less than 40. For the ejection fraction to increase, the patient should be uptitrated with the doses. But most of the doctors feel that all the patient is already stable. Why to uptitrate? Second is, why should I change anything? And he has mild heart failure. Even though the ejection fraction is big, in mid-range, that is 40 to 50, or ejection fraction is preserved, like more than 50, still the patient has high chance of sudden cardiac arrest. So to decrease that sudden cardiac arrest burden or to decrease the hospitalization, even though patient is having mild heart failure, they should be kept on guideline-directed medical therapy. Sometimes patients also, they themselves feel that they can be increased side effect burden, or it is inconvenient for them, non-tolerance, hypotension causing giddiness, and all these side effects are unable to uptitrate the doses. And sometimes treatment follow-up is also a work burden for the doctor. So all this might be the clinical inertia giving optimal medical management. So this slide is an important slide showing right from first time diagnosed acute decompensation to there is a disease progression. So heart failure is a progressive disease. It's not that once the patient stabilizes after acute decompensation, we should not feel that it's a stable heart failure, because always the patients with stable heart failure are also at high risk of sudden cardiac arrest and recurrent admission. So all the patients with stable heart failure are also should also be kept on optimal medical management. So this is one of the classification. So heart failure is classified based on anatomy, based on physiology, and based on ejection fraction. So anatomy is like whether it is right heart failure or left heart failure. Physiology like whether it is systolic heart failure or diastolic heart failure. But now there is a universal consensus on heart failure definition. That is whether it is heart failure with reduced ejection fraction, or heart failure with mid-range ejection fraction, or mildly reduced ejection fraction, or heart failure with preserved ejection fraction. This ejection fraction is nothing but what is the power of the heart during systole, what is the amount of blood that is pumped during systole. The percentage is calculated as ejection fraction. So if it is less than 40%, it is reduced ejection fraction. If it is 41 to 49%, mildly reduced or mid-range ejection fraction. More than 50, it is preserved ejection fraction. And once the patient is kept on guideline-directed medical therapy, the pumping power can increase from 40 to 50. That is, if there is more than 10% increase, those patients are kept as improved ejection fraction. So those patients who are having myocarditis, with the help of medical management, we can definitely increase the ejection fraction. So those patients fall under improved ejection fraction. Those patients who are having pericardial cardiomyopathy, once they are stabilized and once they are kept on optimal medical management, those patients' ejection fraction can improve. That is, the amount of blood pumped during systole can increase. Those patients are classified under improved ejection fraction. So once the patients come to the hospital with heart failure, we should look at their history, whether there is any shortness of breath, orthopnea, pedal edema, raised JVP and all, and physical examination is done to look whether there is any pallor, raised JVP, and ECG showing whether there is any signs of ischemic cardiomyopathy or dilated cardiomyopathy, that is food progression of Fewers complexes and all. And we will send some laboratory tests for biomarkers like NT-proBNP and BNP. If NT-proBNP is more than 135, 125, and and BNP more than 35, those patients can be classified under heart failure. And we'll do 2D echo, which will give us the amount of blood that is found, that is ejection fraction, and we can classify them under heart failure. And once the heart failure diagnosis is confirmed, we should determine the cause and classify them whether it is reduced ejection fraction, increased ejection fraction, or resolved ejection fraction. And once they are kept on treatment, again we should reclassify them, whether they are coming under improved ejection fraction or whether the preserved ejection fraction are going to reduce the ejection fraction and all. So finally, we do like what about the clinical outcomes of the heart failure? Whatever the drugs we need, whether we are reaching the goal of clinical outcomes and quality of life. The clinical outcomes like whether we are decreasing the mortality, decreasing the recurrent hospitalization, whether we are protecting the kidneys with these drugs, and quality of life like whether we are relieving the symptoms, improving the quality of life, and whether we are increasing the functional capacity.
I did not want to disturb.
From the institute, we welcome Dr. Dar. He is directly coming from here.
Good morning, everyone. So it's not my session, but you're listening to one of the brightest young cardiologists. And that's why I wanted to disrupt this session so that you know to pay attention, learn from it. And this doctor could be anywhere in the world, but he has decided to be in Orlando, learn, and listen, and be like him. Clap for him.
Thank you so much, Dr. Dar. And Dr. Dar is founder of many startups, and he is behind encouraging so many youngsters for starting their startups and maintaining it. Thank you, Dr. Dar, for kind words on me. And so these are today I am dealing with some of the challenges that are there in India in managing heart failure. And coming to management of heart failure based on stages. So stage A is like those patients who are at risk of heart failure. That is those patients who are already having diabetes or hypertension or CKD, or those patients who are having anemia, those patients who are having coronary artery disease and all. So all these patients who have risk factors, patients who are having addictions and all. So those patients should be treated or prevented in a lifestyle management way for decreasing hypertension burden. They should be kept on optimal medical management along with lifestyle. And for diabetes now, newer drugs like SGLT2 inhibitor along with cardiolipin, it is one of the most important drugs for treating diabetes. So along with treating risk factors, the next stage is stage B, where the patient is already having a heart disease but doesn't have any symptoms. So those patients who are having heart disease with ejection fraction less than 40, they should be kept on guideline-directed medical management. And those patients who are having heart disease like congenital heart disease, they should be managed with device closures or surgical closures. And those patients who are having symptoms, they are classified under stage C. And those who are having worsening heart failure, they are classified under stage B. So those patients who are having symptoms, first thing that we should do is like we should decongest them with the help of diuretics. Then we should start them on guideline-directed medical therapy. We should start them all simultaneously, and in step 2 we should uptitrate the doses. And in step 3, consider those patients whether the patients are falling under ejection, lower ejection fraction, or whether they are improving. In step 4, if we are unable to treat with only guideline-directed medical therapy, then we should also add device therapy like CRTD and all. Or if the patients are having cardiac arrest, then they should be kept on ICDs. And in step 5, we also should reassess symptoms, lab health status, and LV ejection fraction. If they are improving, that's fine. If they are not improving, they can be considered for final management like cardiac transplantation or for cardiac rehabilitation. So this slide is showing us that ARNIs are better drugs than ACE inhibitors or ARBs, but when the patient is not tolerating ARBs, then they can be kept on ACE inhibitors. If they are not tolerating ACE inhibitors, then they can be kept on ARBs, like telmisartan or valsartan. This is a like amalgamation of whole management of heart failure. So the ones that are in bigger circles, those are the 4 pillars of heart failure management. That is mineralocorticoid receptor antagonists, beta blockers, SGLT2 inhibitors, and dialysis. Those patients who are not tolerating ARBs, we will keep them on ACE inhibitors or ARBs. And those patients who are having lower iron, in spite of having normal hemoglobin also, if they have low iron, to decrease the symptoms or improve the quality of life, we should add iron supplements like ferric carboxymaltose. And those patients who are having atrial fibrillation, which is one of the important triggering factors for acute decompensation in heart failure, we should treat them with anticoagulants and digoxin, which is rate limiting, and dinotrope, and also for pulmonary in isolation, which is a permanent cure for atrial fibrillation. Those patients in ECG having wide QRS or LVPP, we should be referring for cardiac resynchronization therapy. And if the heart rate is more than 70, in spite of optimal beta blocker, then those patients should be kept on ivabradine. And if there is condition, treat them with diuretics, loop diuretics or diuretics. If the patient is having decompensation and not tolerating the 4 pillars, then we should go for newer drugs. So the newer drugs here are vericiguat, which is a CGMP inhibitor, and omecamtiv, which is an inotrope, cardiac myosin activator, thereby increasing the myotropic action.
I think the time we are running short.
Yeah, just 2 minutes. So, and those patients who are not tolerating this treatment, then we should refer them for mechanical circulatory support like LVADs and heart transplant. So this is the timeline of management. We started with decongestion, then we went for inotropic activity, then we went for guideline-directed mental therapy, then came devices. Now it's a personalized model where we are handling genes, proteomics, and biomarkers. So this already I mentioned. So titration. So the patient should be kept on guideline-directed mental therapy within the hospital, that is within 1 to 4 days. Then they should be uptitrated. Beta blockers should be titrated within 7 to 14 days, and other drugs should be titrated from 14 to 28 days. So these guidelines are showing us that in reduced ejection fraction, all the drugs come under class 1. Whereas in preserved ejection fraction, SGLT2 inhibitors come under class 2A, whereas other drugs come under class 2B, based on evidence. So, what all we can do is to decrease the heart rate mortality, which is most common cause for death all over the world. Start them on all the 4 drugs simultaneously, not sequentially. Uptitrate them and improve the adherence, improve the follow-up, and if we can percolate or permeate these guidelines to last of the last doctor, then we can definitely decrease the mortality burden, morbidity burden of heart failure, and even prevalence of heart failure. So this slide is showing that for the computer to reach 50 million subscribers, it took 14 years. For the Twitter to reach 50 million subscribers, it took 2 years. But how much time will it take for these guidelines to reach the end, the last patient, is the question here. And if we all together join hands, we can definitely accelerate the expansion of these guidelines to the last patient. So, to summarize, heart failure is a malignant, heart failure becomes a malignant progression, and all therapies should be escalated to target dose unless side effects preclude their use. The 4 fundamental drugs for heart failure with reduced ejection fraction should be utilized for all as they provide incremental benefit and improve survival. The physician inertia should be minimized and patient motivated for long-term polypharmacy to improve survival. Developing healthcare infrastructure in the country, availability of digital consultations and counseling will definitely decrease the heart failure burden. Thank you.
Sir, thank you very much for perspective on the heart failure. But one question for you regarding heart arrest and cardiac arrest and cardiac failure. Please, can you describe?
Yeah, so those patients who already had an episode of cardiac arrest and they survive the cardiac arrest after CPR, they should be kept on, they are the patients indicated for ICD. For ischemic cardiomyopathy, we should wait for 40 days for optimal medical management and then go for ICD, or for non-ischemic cardiomyopathy, directly we can go for ICD, implantable cardiac defibrillator, which can give shocks even the patient is out of the hospital and can manage. And definitely all the guideline directed medical therapy, especially ARNIs, have shown in most of the trials that it has reduced sudden cardiac arrest burden by 25%. These guideline directed medical therapy also decrease sudden cardiac arrest burden.
Now the session is open for questions, or one or two questions.
Good morning, sir.
Good morning.
So my question is the new drug which is called the miracle of heart failure, Xadians. Is it applicable for the heart failure, or else 4 pillars of heart failure drugs are important for the heart failure?
These 4 pillars are only important.
So new drug is like Xadians now. What's its mechanism of action? How it affects the heart failure patients?
Xadians.
Empagliflozin.
Empagliflozin, yeah, okay. So those are nothing but SGLT2 inhibitors. Empagliflozin is an SGLT2 inhibitor. Empagliflozin, dapagliflozin and all. Even now in solitary heart failure, recent trials, sotagliflozin also has come into the market, which is also a latest drug of SGLT2 inhibitor that can also decrease mortality and mortality. So those are already under 4 pillars.
Apart from SGLT2 inhibitor for receptor, so we can only administer beta blockers to the cardiac patients?
No, that is what I was telling you. That is start the patient on all the 4 pillars. So starting, it's not just beta blockers. Previously, there were only like ACE inhibitors, beta blockers, and intracortical receptors. But in the advance of inhibitors like ARNIs and SGLT2 ARNIs have replaced ACE inhibitors and SGLT2 inhibitors have added to this triple drug therapy. That is quadruple therapy. Starting them on all the 4 drugs simultaneously will help, rather than sequential drug therapy. Adding one drug and starting them on other drug later will not going to help. So starting them simultaneously is going to help the patients.
Thank you.
Any more questions from the audience?
Thank you, sir, for your valuable session. I request Dr. Jhala Srinivas, sir, to conclude this session.
First of all, I appreciate all the audience for being participating in this conference, international conference. And I thank Dr. Bhagirath sir inviting the cardiac heart failure, and hope you get it. And my request to sir is that let him post the mail ID so that they can have the questions in the mind. Now it's not the time to ask. So please give your mail ID, sir. It will be helpful to the student community for getting these things. Thank you very much, sir. Thank you.
So my mail ID bhagirat.atte@gmail.com.
Now I request Chairman Dr. Jhala Srinivas, sir, and Co-Chairperson Dr. Manesh to felicitate the speaker of this session, Dr. Bhagirath, sir. Sir, please accept as a token of gratitude.
Yes, sir. Okay, sir. One more. 1 second. 1 second.
Now I request Dr. Bhagirat sir and Dr. Manik sir to felicitate the chairperson of this session. Dr. Chala Srinivas sir.
Yes, sir.
Now I request Dr. Chala Srinivas sir and Dr. Bhagirat sir to felicitate the co-chairperson of this session, Dr. Manik sir.
हाँ सर.
We are looking forward to our next session on significance of adult immunization. We are truly honored to have some eminent personalities on this session. I am the chairman of this session, Dr. Kamal Yadav, Principal of Vagdare Pharmacy College, Balikunda. And the chairman, Dr. Sharmana Baba, HOD of Vagdare College of Pharmacy. And the speaker of this session, Dr. M. Magana Ma'am, Senior Resident of Father Colombo Institute of Medical Sciences.
Sir. Madam. Yes, ma'am.
Now I request co-chairperson Dr. Sharmana Baba sir to introduce the speaker of this session.
Good morning, everyone. I'm privileged to introduce Dr. Meghna Mulligan Madam, MD General Medicine. She has done MBBS from Karthia Medical College, Warangal. She secured 4 university gold medals during MBBS and MD graduate from Bhaskar Medical College, Hyderabad. She has done her fellowship in diabetology from Royal College of Physicians, London. With this short note, I would like to invite Meghna Madam Dr. Magna Madam to start the session.
Myself, I am Dr. Meghna. I did my MD General Medicine. I thank everyone for giving me this opportunity. Today, I want to discuss you all about adult immunization. It is the most neglected topic, but it is the need of the hour, and it is the most important topic actually to be discussed. First of all, what is a vaccine? A vaccine is an immunizing agent which is derived from microorganisms. It can be in the form of live or attenuated form, or kill the microorganism, or even extract of microorganism is used for preparation of vaccine. Many people have a doubt that is vaccination safe? The vaccination practices that usually weigh between the benefits and risks caused by vaccination, and then we will proceed. There are two types of immunization, that is active immunization and passive immunization. In active immunization, we directly give the organism and then our body generates the immunity against it. Whereas in passive immunization, we directly inject the exogenously produced antibodies so that our body will respond. Generally, active immunization is used for pre-exposure control and passive immunization is used for post-exposure control. What are the major types of vaccines available? It can be like live attenuated vaccine, or inactivated, or toxoids, or subclinic vaccines. Why does adults actually need vaccination? Some adults were never vaccinated during children, and many vaccines were not available when our adults were children. And as we age, the immunity also decreases, that is immunosenescence, and our resistance to fight with the infections also decreases. And it also contributes to herd immunity in vaccine-prevalent diseases. Even if some people in the community are vaccinated, it helps to prevent the chain of the disease. So, it helps in decreasing the severity of the disease progression. More than 15 years account for about 72% of Indian population, and proportion of adults dying because of vaccine preventable disease is 354 higher than that of in children. Though many national immunization schedules came for children also, for every 5 children, 1 child is being unimmunized according to the recent studies. What are the bottlenecks in adult immunization? We don't have awareness, we doubt regarding the efficacy of vaccine, and these vaccines are not covered in national immunization schedule, and the cost being a barrier for adult immunization. What are the adult vaccines which are recommended in India? We need to give the booster doses of our childhood vaccine. We need to give the missed vaccines which were missed during our childhood. And few vaccines are specific for adolescent age group. And for people who are at high risk and travelers also, the meningococcal, Japanese encephalitis, yellow fever, and cholera vaccine should be covered. This is the most important vaccine to be covered in this session. Only 2 cancers can be preventable by vaccination. That is cervical cancer, which is caused by human papillomavirus, and hepatocellular carcinoma, which is caused by hepatitis B virus. These 2 cancers can be solely prevented with vaccination. Because of lack of this awareness, India is contributing to 25% of global load of cervical cancer. In India, every year, 122,844 cases and 67,477 deaths are occurring because of this cervical cancer. That is around 334 cases per day and 185 deaths every day. Taking these all census into consideration, every 8 minutes, 1 female is dying because of cervical cancer. India ranks second most common cervical cancer leads in second most common cancer in women in age group of 15 to 45 years after the breast cancer. The younger the better for HPV vaccination because adolescent females may have increased susceptibility for infection compared to adults. and HPV vaccination should be given to females before they reach the age when the risk of HPV infection increases. HPV virus, maybe 200 serotypes were identified. Among the 200, 40 can affect the human, and among the 40, 30 can particularly target the genital mucosa. And there we have high risk and low risk type of subtypes of HPV. Among the high risk type, 16 and 18 can cause around 87% of cervical cancer in India. Low risk type that doesn't contribute much to the cervical cancer, but they lead to the genital warts. WHO has mainly kept 3 goals for cervical cancer. That is, WHO has decided that 90% of the girls should be fully vaccinated, 70% should be screened properly for the HPV by pap smear, and 90% who be diagnosed as cervical cancer should be started on treatment. But according to current reports, only less than 0.5% are being vaccinated. Coming to the next, the national history of HPV, there will be in the first 1 year period, only HPV infection will be present. Slowly, it will develop into cervical intraepithelial neoplasia, and over the 20 years progression, it develops invasive cervical cancer. What are the available vaccines for HPV? We have Gardasil 4 and Gardasil 9 and Cervarix. Initially, Cervarix was present, which was bivalent, but not used nowadays. Gardasil 9 and Cervarix. It can be used in males and females. Now you will be getting it out. HPV vaccine should be given even in males or only in females. HPV vaccine should be given both for males and females. Normally, Gardasil 4 is given in adolescent age group as 2 doses, in adult age group as 3 doses. Gardasil 9 in both males and females, it is given as 3-dose regimen. Even same with the Cervarix, for adolescent 2 doses, and for adult age group 3 doses will be given. No data regarding the HPV vaccine in pregnancy, but it is safe in lactation group. Long-term efficacy and results were very good with the HPV vaccine. They have studied for about 12 years, and the protection against HPV remained high with no evidence of decreasing over time. So currently, no boosters are required for HPV vaccination. So as I already said, for every 8 minutes, a woman loses her battle for cervical cancer in India. Don't let it be you or your family member or your friend. The reason why males should also get this HPV vaccination is it can also affect the penile, it can also lead to penile cancer, it can also lead to throat cancer, and it can also lead to anal cancer. That's the reason why HPV vaccination should be done in both males and females. So we can take a case scenario which you see commonly in a casualty. We have got an 18-year-old person who had got a minor injury, came to the casualty asking for TB. What we generally do is, when a patient came with any wound, we generally give him the tetanus toxoid. But what should be the guideline to be followed behind that? This is a table which we universally follow, that we categorize the patient into 2 categories. Whether the patient is having clean minor wounds or all other wounds. In clean minor wounds, we don't give any tetanus immunoglobulin. But if we don't know the vaccination schedule, whether the patient has taken the 3 doses or not, and if the last dose was more than 10 years, the booster was less than 10 years, then we give the tetanus containing vaccine. Or else no need of giving tetanus containing vaccine. For all other wounds, if we don't know the vaccination schedule, then we need to give the tetanus immunoglobulin. And here, they have decreased to 5 years. If the last booster dose was less than 5 years, then we need to give the vaccine. Or else, no need to give the TT vaccine. One more important thing is, even for pregnant women, gynecologists advised to give the Tdap vaccine. Tdap stands for tetanus, diphtheria, and accentual pertussis. For pregnant women, if the last dose was more than 10 years, then 1 dose is recommended either in second or third trimester. If the last dose is in between 2 to 10 years, 1 dose is after delivery. If the patient was never vaccinated, then we need to restart the schedule, that is 3 doses, 016. During an outbreak, if patient is previously unimmunized or the booster was before 2 years, then we need to give 1 dose of Tdap. Coming to influenza vaccine. The major problem lies with influenza vaccine because influenza virus gets mutated frequently. It gets mutated frequently and new strain will be formed every year. So we need to generate new type of influenza vaccine every year. The data will be released from WHO Global Influenza Surveillance and Response System. This data will be given to the manufacturers 4 to 6 months prior to the flu season. That is October to May will be the flu season. So 4 to 6 months priorly they will be starting the production of vaccine and then we need to give the vaccine to the patient. As this influenza is very frequently mutated, this influenza vaccine should be given every year. How effective are flu vaccines? 40 to 60% efficacy is there, but it can vary from season to season. This flu vaccine will reduce the severity and ICU admissions and death. WHO recommends annual influenza vaccination for pregnancy, children between 6 months to 5 years, for elderly individuals and individuals with chronic medical conditions and healthcare workers. What is varicella vaccine? Varicella zoster is nothing but what we generally call as chickenpox. Chickenpox vaccine should be given in all susceptible adults and adolescents. Mainly important for healthcare workers and family of contacts of immunocompromised and high-risk exposure group, that is teachers and daycare employees. Generally it is given as 2 doses, 6 to 8 weeks apart, but if you have missed the second dose, it is more than 10 weeks, no need to restart the schedule again, you can just give the second dose. Post-exposure prophylaxis. If you are exposed to a person with chickenpox and you were not vaccinated previously, then within 3 to 5 days of exposure, you need to take at least 1 dose of varicella zoster. What is herpes zoster? The varicella zoster, which we were affected during our childhood, will be reawakening in our adulthood, and that leads to shingles. That is herpes zoster. It is sad to know that 20 to 30% can expect to get the shingles in their lifetime. The lifetime risk of zoster is 10 to 30%, and this risk of being affected with herpes zoster increases with age, and it increases up to 50% for 85 years age group. Initially, there was a vaccine called Zostavax, which was live attenuated vaccine, which was given in single subcutaneous form, recommended for more than 60 years, which was only 51% effective against shingles and 67% effective against post-herpetic malaria. But we are lucky that we have invented a new vaccine, that is Shingrix, which is a recombinant subunit vaccine given with 2 IM injections. And its efficacy is around 97% when compared to 51% with Zostavax. And it is 88% effective against post-herpetic malaria. But only problem with Shingrix is cost. Each dose costs around 10,000. So we already discussed the patient needs 2 doses. So it takes around 20,000 to give the 2 doses of Shingrix vaccine. Pneumococcal vaccine. 2 vaccines are licensed in India for adults. That is pneumococcal polysaccharide vaccine 23 and pneumococcal conjugate vaccine 13. Pneumococcal vaccine usually not recommended less than 65 years unless the patient is having any risk factor. That is, if the patient is having any cochlear implants or CSFT or implant screening function or immunocompromised individuals. Here I want to highlight a point that generally our screen is helpful for us to fight against the capsulated organisms, that is meningococcus, pneumococcus and the Haemophilus influenza. Whenever a patient is undergoing splenectomy, we need to vaccine the patient with these 3 vaccines. A single dose of PCV13 should be given, followed by 2 doses of PPSV23. Even in the age group, there will be PCV13 followed by PPSV23. Minimum interval should be 8 weeks between the first and the second dose. It is given as a single dose and no booster doses or second dose is needed for TPCP, but it has not launched yet in India. MMR vaccine. Actually, this vaccine is invented in 1985. So, and this vaccine is added to the schedule since 1985. So, adults who were born before 1985 was never given this MMR vaccine. MMR vaccine should be given as 2 doses, should be given as catch-up for those who miss it, and it should be important for healthcare workers because they will be frequently exposed to mumps and measles and rubella. It is also used for post-exposure prophylaxis if given within 72 hours. Hepatitis B vaccination. It is most important for all of you who are present over here. It should be given as 3 doses, 0, and then after 1 month and then after 6 months. After getting the 3 doses, after 1 month of getting these 3 doses, we need to get the antibody level done. If it is more than 10 milli international units per ml, then you are having a good level of antibodies in your body. If you are having less than 10 milli international units per ml, you need to take the dosage again. Then again you need to take the 0-1-6 dose schedule and then repeat the antibody level again. If still you are having less than 10 international units, 10 milli international units per ml, then you are labeled as poor responders for hepatitis B. These poor responders, when exposed to hepatitis B, instead of this vaccine, they will be given immunoglobulin. Coming to hepatitis A vaccine, there are inactivated vaccine and live attenuated viral vaccines. These inactivated vaccines are the ones we mostly use for hepatitis A. Minimum age of administration is 1 year. 2 doses should be given 6 to 18 months apart. Who should be given hepatitis A is people who travel to endemic area of hepatitis A or who work in a laboratory or patients who are receiving frequent blood transfusions or frequent clotting factors or patients who are infected with other hepatitis viruses like A or C or D or E or chronic liver disease or patients who are awaiting for a liver transplant and homosexuals. Rabies. One sad thing regarding the rabies is if you haven't taken pre-exposure prophylaxis for rabies or you haven't started post-exposure prophylaxis, rabies is usually spread by cat bite or dog bite or mosquito bite. We need to take the post-exposure prophylaxis for rabies for sure. According to the data, till now only 29 people in the world survived after being affected with rabies. 3 doses will be given in the pre-exposure. Generally, we don't take any pre-exposure prophylaxis. Only those who are having these pets who are not vaccinated or who are pet handlers or who are working in laboratories, they will take the pre-exposure prophylaxis. Post-exposure prophylaxis, it can be either intradermal or intramuscular. This rabies bite, or any dog bite or cat bite, we generally categorize into 3 categories. In category 1, we have only mild, there will be only mild nicks on the intact skin. There are no scratches or no abrasions with the bite. In that category 1, no need of any vaccination. In category 2, there is scratches are present because of the animal, but there is no significant bleeding. In category 2, we give only vaccine, no need of immunoglobulin. In category 3, there we are having severe bites or scratches along with bleeding. There we have high transmission of rabies. So here we give rabies vaccine along with immunoglobulin. It is generally given in the form of 5 doses, that is 0, 1, 7, 0, 3, 7, 14, 21 or 28. Meningococcal vaccine, generally there are many meningococcal vaccines, but in India we have only 2 vaccines, that is meningococcal conjugate vaccine, Menpio or Menecra. Meningococcal vaccine is usually recommended for travelers who are traveling for the meningitis well or pilgrims who are going to Hajj and Umrah, students who are going to study abroad and during the outbreaks and high risk group. In high risk, who comes under high risk group for meningococcal are infections, and HIV and sickle cell disease. For travelers, single dose at least 10 days before travel should be given. Japanese encephalitis vaccine for individuals living in endemic countries and travelers to Japanese encephalitis endemic areas, provided they are expected to stay for a minimum of 4 weeks. In India, we have Jet-Vac and JE Shield, which is given in a single dose, and G Alert, which is given in 2 doses. Yellow fever vaccine, it is prepared from 17 strain of the virus. It is live attenuated vaccine. Single dose is enough. Efficacy of yellow fever vaccine is very good. It is more than 90%. For all the travelers, mostly they ask for the yellow fever vaccine. It becomes valid only after 10 days of the vaccination, but it is valid in lifetime. Problem with yellow fever vaccine is it is not available in any private sectors. It is available only in government sectors. Vaccination against polio for travelers. Usually in India, polio has been decreased because of our good initiation by government and pulse polio immunizations and all. But passengers who are going for Kenya, Nigeria, Ethiopia, Somalia, they are all having polio cases even now. So along with the polio, they need to get the yellow fever vaccination. They need to get the vaccine 4 weeks prior. Oral polio vaccine is valid for 1 year. Recently, we used to give oral cholera vaccine. It is not usually recommended, but it is recommended only in high transmission areas, given in 2 doses. Revaccination is recommended after 3 years if the patient is having continued risk for cholera infection. Coming to the SARS-CoV virus, as COVID has been, we are seeing since the past few years, we have tried to create vaccines using different methods. We tried by using the nucleic acid-based vaccines or immune cell therapy or whole cell virus or viral vector vaccines. These are by different manufacturers which were being used. Pfizer was based on mRNA, Moderna, AstraZeneca, Johnson & Johnson, and Sputnik, Sinovac, and Novavax. But in India, we used Covishield and Covaxin. Covishield was a live attenuated vaccine which was prepared by Serum Institute of India, whereas Covaxin, it was as Covaxin. In the says that it is an inactivated vaccine, whereas Covaxin was live attenuated vaccine. Covaxin is inactivated vaccine. Initially, we gave these vaccines 14 days apart, but later the guidelines were changed and they said to give the second dose after 2 to 3 months. What are the vaccines recommended for healthcare workers? For healthcare workers, we all come under healthcare workers, so we need to get vaccinated mainly for hepatitis B, influenza, and MMR vaccine, and chickenpox vaccine, Tdap, and meningococcal. Vaccines to be recommended prior to pregnancy. Prior to pregnancy, MMR and chickenpox vaccine must be given. Hepatitis B, if they are not already immune, HPV and influenza every year. Here, MMR and chickenpox vaccine, both are live vaccines. Usually, live vaccines are contraindicated during pregnancy. So, after giving MMR and chickenpox vaccine, we usually recommend them not to become pregnant within 1 month. Co-administration of vaccine. Can multiple vaccines be given at a time? We can give any number of vaccines on the same day, but should be given at a different site. But 2 live vaccines should not be given on the same day. The time gap between the 2 live vaccines should be at least 4 weeks. Coming to the summary of all the vaccines which we discussed now, this is according to the adult immunization schedule, India. Tdap vaccine should be given for all with the booster dose for every 10 years. HPV vaccination, it is better to give 19 to 26 years because they are more susceptible at that age group. 3 doses should be given. Varicella can be given at any time 2 doses should be given. Zoster, as zoster is seen mostly after the 60 years age group, so 1 dose is given after 60 years. MMR is mostly applicable in adult and adolescent age group. That's why it is must for those age group. And after 50 years, if any risk factors are present, 1 dose is given. Influenza vaccine after 50 years, 1 dose is given annually. Pneumococcal vaccine should be given after 1 dose. Hepatitis A, B and meningococcal should be given only for all the high risk persons. Screening should be done utilizing the health. Taking these conditions, we need to take health condition into consideration, age, lifestyle and occupation of the patient, and we need to document properly regarding the date of vaccination, and we need to intimate properly regarding the next dose to be given and vaccine manufacturer, dose and site of vaccine, and the vaccinator details. You need to administer to the right patient and the right vaccine, right dose, right route and right time. Thank you. I request all to pledge yourself today that we are going to be a part of spreading awareness on adult vaccination, which can save many lives. Thank you.
Thank you, madam. Good morning, all of you. So, any questions from delegates?
As you said, MRN has mutated viruses after every year vaccination. So, yeah. So, coronavirus is also an mRNA virus undergoes frequent mutation. So, should we take vaccination every year?
No, they are not as frequently mutated when compared to the influenza vaccine. The influenza vaccine, there will be antigenic shift and antigenic shift, both will be frequently. So there are not much mutations noticed in the COVID vaccine as compared to influenza vaccine. That is a major problem, sir. As India is leading cause for HIV, we need to create vaccine for HIV, but still not available in India.
One more question. Can we get HIV and rabies with mosquito bites?
No, sir, no. HIV doesn't spread with mosquito bite or any saliva or any body fluids. Only hepatitis B spreads even with the body fluids. That's the reason we request all the healthcare workers to vaccinate with hepatitis B.
Last, anyone? We are running out of time. Thank you. Madam, I have a question. Here, madam. Madam, 60 plus is the risk factor age for post-herpetic neuralgia.
Yes.
You said Shingrix and Zostavax.
Yes.
What might be the age group to receive to prevent this herpes zoster if they are at risk families are there?
It's better if you give them under 50 years.
50 years.
50 years onwards, the age group is increased to 30%, which is a very high number. So after 50 years, it's better to get vaccinated with the herpes zoster vaccine.
Thank you, madam. Thank you.
Thank you, ma'am, for your helpful sessions. I request Dr. Kamal Yadav sir to conclude the session.
And thank you, madam. You had a nice way that is the current issue. Really wonderful session. I thank you very much, madam. So, any queries, any doubts, send to the mail already given by the mail. Okay. So, thank you very much for inviting me and also rush to arrangements of suppose inaugural session. Thank you very much.
Dr. M. Marina ma'am. Ma'am, please accept this as token of our independence.
Just side you. Sir, closer. Together.
Now I request Dr. Sharvana sir and Dr. Meghna ma'am to felicitate the state person of the session, Dr. Kamal Yadav sir.
किती करतो सर ते కొంచెం డౌన్ చేయండి ఓకే లుక్ హియర్ సార్
Now I request Dr. Kamal Yadav sir and Dr. Meghna ma'am to felicitate the co-chair person of the session, Dr. Sharvana sir.
మనకు ఆత్మ వస్తుంది తీయడానికి ఒక్కసారి ఒక్క ఫోటో కోసం
Myself, Abhinaya from B.Pharmacy final year.
Myself, Yunus Mohammed from Family Third Year. On behalf of the managing committee of this event, that is Tala Padmavati College of Pharmacy, in collaboration with Father Colombo Institute of Medical Science and Medicare Hospital, Varangal, in accordance with Avenida Innovations, Hyderabad. Once again, I would like to thank every one of you for joining our event. Your presence is really appreciated, and we hope you all will enjoy with us till the last of this event.
Let us invite our special dignitaries onto the dais. With a big round of applause, I would like to invite our most assailable and admired principal of Tala Padmavati College of Pharmacy, Ms. Nanada Jain, Dr. J. Venkateshwar Rao sir, to honor the dais.
It's time to invite the most scrupulous person on the dais, Professor Beti Srinivas, Principal, Tala Padmavati Pharmacy College. Now I invite Professor Satyanarayan Patnaik, Tala Padmavati College of Pharmacy on the dais.
Here comes a virtuous person, Dr. Varun Tala, Director of Tala Padmavati Group of Institutions, onto the dais. We are privileged to invite a man with intended mindset, Dr. Vanshi Tala, Director of Tala Padmavati Group of Institutions, onto the dais.
It's time to invite a person who is a founder of NGO, volunteer with Isha Foundation, and a mentor of hundreds of students. He is none other than Dr. Karthik Rakam, CEO and co-founder of Avenida Innovations. It's our opportunity to introduce Director of Father Colombo Institute of Medical Science, Warangal, Reverend Father T. Tharun Reddy, onto the dais.
I profusely haste to take an opportunity to invite our guest of honor, Reverend Father Chinappa Reddy, Director of Medical General Hospital, onto the dais. It's time to invite Dr. H. Sandhya Rani, Principal of the Colombo Institute of Medical Sciences, Warangal, onto the dais.
We hereby invite a person with fortune, ideas, and gracious heart, Dr. V. Mahendra Reddy, Medical Superintendent, Medicare General Hospital, Warangal. Now I hereby invite a person with great wisdom, who is a perfect version of simplicity. He is Professor Y. Narasimha Reddy, Dean Faculty of Pharmaceutical Science, Kakatiya University, onto the dais.
Here, it's time to invite a person with great accomplishment, contributions towards his profession, with keen interest for molding students' career. He is Sri Tala Mallesham, Chairman of Tala Padmavati Group of Institutions, onto the dais. With equal honor, we are privileged to invite our mentor, Sri N. Narayan Reddy, Chairman, St. Peter's School, onto the dais.
Now here I invite the chief guest of today's event. He is the person who is most celebrated foreign dignitary in His Excellency, Dr. Ashwani Dhar, Chairman and CEO of King Roman Ventures, United States.
Now, I request all the dignitaries on the dais to join us on welcoming the most Reverend Father Dr. Udumala Bala, our chief guest for the day. He is a galaxy of intellectuals, graceful personality. Most Reverend Father Dr. Udumala Bala, the Bishop of Warangal and Chairman of the Colombo Institute of Medical Sciences. Now I request all the dignitaries. Now it's time for our traditional lamp lighting ceremony. As we know, light is dignity of life. It shows the right direction of life. Now I would like to invite every one of you to kindly stand up and join us in lamp lighting. I request all the dignitaries to light the lamp. And I invite P. Tashvika and Sushmita for a prayer song.
Sandhya
With a big round of applause, I would like to invite Dr. J. Venkateshwar Rao, Principal, Tala Padmavati College of Pharmacy, to give a welcome address to our audience.
A very good morning to all of you. The chief patron of today's function, Most Reverend Dr. Rumala Balasar, Bishop of Warangal and Chairman of Medicare Hospital and FCIMS, and the chief guest of today's function, Dr. Ashwini Dhar, CEO, Think Venture USA, and Dr. Vijay V. Eldadi sir, Vice President, Continental Hospital, Hyderabad sir. Wholeheartedly we are welcoming you sir. And our mentor, Sri Narayan Reddy sir, Chairman, St. Peter Educational Institutions, Warangal, and our special invitee, Professor Y. Narasimha Reddy sir, Dean Faculty of Pharmaceutical Sciences, Karti University, Professor B. Mahendra Reddy sir, Medical Superintendent, Medicare Hospital, and Professor H. Sanjay Madam, Principal, FCIMS, and our beloved Chairman, Sri Tala Malesham sir, Tala Padmavati Group of Institutions, and guest of honors, our Reverend Father G. Chinnapareddy sir, Director, Medicare General Hospital, and Reverend Father T. Tarun Reddy sir, Director, FCIMS, and Dr. Karthik Ragam and young directors on the dais, Dr. Vamshi and Dr. Varun, and my friend Bedi Srinivas, principals of TPCP, and eminent invited speakers, Dr. Sadhdev sir, Dr. Meghana Madam, Dr. Badiga sir, Dr. Mohammad Sibagatullah, and Dr. Neeraj Davoy, Dr. V. Pradeep, and Dr. P.V. Geetanjali, and Ligita. A special invitation to everyone, dignitaries on the dais, off the dais, all the faculty members from the TPCP, TPPC, FCIMS, and principals, HODs of the and faculty members from other pharmacy colleges, my dear students from TPCP and FCIMS, TPPC, and other colleges, representatives from the print and electronic media, ladies and gentlemen, once again a very good morning to all of you. I welcome you all to this TPCP International Clinical Pharmacy Conference 2023. I am extremely delighted to be part of this academic event, which is organized by the Department of Clinical Pharmacy, Tala Padmavati Institutions, in collaboration with prestigious institution Father Colombo Institute of Medical Sciences and prestigious hospital, Medicare General Hospital, in association with Avenida Innovations. This event also a part of ongoing activities of IPA Warangal City Local Branch. Recent times have witnessed a redefinition of the role of pharmacists, particularly clinical pharmacists, driven by the urgent demand for optimal clinical outcomes. The seamless collaboration between physician and pharmacist is integral to achieve the overall success in healthcare. This convergence of expertise and knowledge is crucial in today's healthcare landscape, where interdisciplinary collaboration is key to achieving the best outcomes for patients. Under the esteemed patronage of our beloved chairman, Sri Tala Malesham sir, Tala Padmavati Group of Institutions has meeting the qualified manpower needs of the healthcare sector for the past 26 years. I am very much thankful to his wholehearted support. On this occasion, it's our pleasure to have a most reverend Dr. Rumala Balasar sir, Bishop of Warangal and Chairman of FCIMS and Medicare General Hospital. He agreed to come over here despite his busy schedule. I sincerely thank him for accepting our invitation and blessing us with his auspicious presence. My sincere thanks to Sri Narayan Reddy sir, Dr. Ashwini Dhar sir, and other dignitaries on the dais, especially Vayana sir and medical directors and superintendent, and also the guidance, wholehearted support for making this grand academic event happen in our Medicare hospital. Thanks a lot, sir, everyone on the dais with your kind support. But I must thank definitely the guidance of Father Chinnapareddy sir has shaped this event. Wholeheartedly we are thankful to you, sir. Thanks, sir, due to renowned person Dr. Ashwini Dhar and Karthik Ragam who has been our close associate for a long time, for arranging the scientific session for this conference. Thanks a lot, sir. And also, I am very happy to announce that we have an MOU with Avenida Innovation, which will be very useful for the overall benefits of the patient of Medicare General Hospital. This will also benefit the students of Tala Padmavati as well as the FCIMS with improved clinical skills. I am thankful to all the resource persons, especially Dr. Y. Vijay sir and others who are associated with the reputed hospital setups across the nation and have ample practical exposure in patient care as a consultant clinical pharmacist. Thanks for sharing your valuable time with our students. I am very happy and equally proud to announce that this conference is one of the first of its kind to have all the resource persons who are all active in clinical practices with practical exposure to diverse clinical situations along with the MBBS students of our Father Colombo Institute of Medical Sciences. I hope the delegates will benefit from the expertise of our resource persons and the students will get motivated to build their careers in clinical pharmacy. I would like to express my sincere thanks to my loving students and all other students coming over from the United and Varangal. And thanks to all the staff members and students of Tala Padmavati institutions and who worked for this conference of all the staff of Medicare as well as the FCIMS. Finally, I must thank our beloved chairman, Sri Tala Malisham sir, for his support and encouragement. We'll try to have a more such beautiful academic events under his supervision. Without sparing much time, I invite all the delegates to participate in the forthcoming scientific session. Once again, thank you to one and all. Thanks a lot.
Thank you very much, sir, for your very words. It's time to invite Dr. Karthik Rakam, the CEO and co-founder of Avenida Innovations, to address our audience.
Hello and namaste to all the professionals on stage and all my friends off the stage. So hello. It's louder little. Yeah, so whoever is sleeping will wake up. That is how loud you should be. So for funding to not to take off the way it should have taken off, there are certain factors which most of you are aware. So one of them is not having proper collaboration with the affiliated hospital. Do you agree with me? So do you think that limits the scope of funding? Yes, no. So always I know English language, Telugu language, not body language. Okay? So and Dr. Khan is known for any teachers wherever he goes. If it is yes, this is how you do this. Okay. So, but I think by this collaboration we are addressing that issue. So I am very thankful to Father Colombo Institute of Medical Sciences and Medicare Hospital, which is the first and foremost step for family program to be successful, is to have a proper association and collaboration with the hospital, which is lacking at most places, and I think this is one positive step we have taken in the direction. And the second step is the vision of pharmacy college. So it can be just offered as one more course where student take admission, they finish 4 years, 6 years and they get a degree at the end of the day. But many colleges lack that vision or that support to take it to next level. So here the second aspect is also taken care thanks to support from Malaysian sir and both the directors. So support from college is also taken care.
A few months back in the college, that is the Colombo Institute, Father Colombo Institute of Medical Sciences. This is the second program. So the college is organizing a wonderful program So especially on the clinical pharmacy, it is the most useful for PharmD students as well as pharmacy students. And so it is so first of all, my hearty congratulations to the college, principal and the management for organizing this wonderful program. So that is the International Clinical Pharmacy Conference 2023. So it is very useful for all the students. So I think it is the first college to conduct the program, this international program, international conference, especially on the clinical pharmacy. And most of the conferences I attended related to pharmacy. So it is specifically it is a clinical pharmacy. So this is a very good opportunity. And the speakers are the resource persons from the various parts of India and abroad. So it is very great. So I think I wish this program will be grand success, and also I wish the college will conduct more programs for the useful of students as well as the faculty members. Thank you, one and all, for inviting me for this program.
Thank you very much, sir. We are staying with your voice.
Now I would like to invite our mentor and Narayana Reddy, the chairman of St. Peter's Edu School, Warangal.
His Excellency Bishop of Warangal, elders on the dais, CEOs on the dais, fathers, principal of the college, and other members on the dais. Principals of the various colleges and faculty of various colleges and medical students as well as PharmD students of various colleges of the dais and this. It is most important thing I want to say for all of you. There are several changes in medicine as well as pharmacy. Most of you may be knowing it, and shortly the government of India and even including Telangana government is serious about preparation of the students in the pharmacy, even in the medicine. We are supposed to conduct such programs very frequently so that the people will be knowing what exactly is going on outside the college. Because college is only confined to a certain syllabus. But this program will not be confined to the syllabus. It is confined to the changes in the society. So I appreciate our Bishop for accepting the PharmD students as well as the CEOs from various parts of the country as well as out of the country. And I should appreciate even Padmavati Manishan sir and his team, because we know both of them. They are meant for the quality, they are meant for even spread the quality for among the people in the field. So this is a golden opportunity for the students studying pharmacy, PharmD, and students from the medical college, that we should know what are the changes and how we can also materialize the course which we are studying. Until unless we know this, we cannot go further. And we are also fortunate that Karthi University also is implemented this program, and certainly we will be able to spread this idea among the university colleges. So that also will help us. So here I want to say only one more word and stop. First thing is, our medical college is having a collaboration with St. John's as well as with Father Manlo, including other part of the countries. So this way, this program certainly will be extended even further many, and even such programs also I want to request to see the associates further and see that our students will be benefited faculty will be benefited, and institutions also will be shown that the quality is important for us rather than the only establishing the colleges. So I want to request the different colleges who have come from different places, please see that at least a few programs, if you conduct at your institutions, so this will be able to enable the students to know what is going on outside. So I appreciate the team who has taken the responsibility from the institution, particularly Madam Principal, fathers, as well as their team, with the collaboration of the Padmavati College. And this is not only second program, further there will be several programs which will be conducted in our campus. So I hope such programs will certainly help for the faculty as well as students. Thank you.
Very much, sir. We are really excited to hear from you today. It's time to invite our special invitee, Dr. Ashwani Dhar, the CEO of Think Roman Ventures United States, to address our audience.
Good morning. So I'm not going to test who's awake or not. You are awake, it's okay. You're not, then it's your loss. Because I don't have much to lose anymore. You know what I'm saying? So I think I'll tell you a simple thing. I'm not here to tell you how to live your life and all that. There are lots of people and you're already on Instagram and they tell you what to do today and tomorrow. But I'll tell you something. What is a very good thing I saw today, or for the last few days. I have, by the way, I live in California, USA, and my tagline is that I'm a proud Kashmiri by birth and American by choice. In case you are thinking, where did you get the good looks from? So that's Kashmir. So one thing I was so impressed. So I've been not coming to India much. I came 3 years back for the first time after 15 years. And Dr. Karthik Rakam, who is part of us at Avenida, has already done a lot of work with the founding students. So what I'm trying to give you the backstory is, I was so encouraged, but I was also disappointed a little, because where I live now, what I call home, pharmacy and medical, so I'm a doctor by profession, but having in corporate and startups and so on. One thing I noticed here is that pharmacy people are not part of the clinical care, whereas in the US, if I'm grounding on an ICU, my clinical pharmacist is more important. I just say it's hyponatremia and then they figure out what needs to be done. So I am so happy today to see medical students and pharmacy people together. So a round of applause. So in that way, it is historic. So I will tell you, to see the transformation happen in just 2 or 3 years for me especially. So I came to this place 2 years back. It was still kind of a building. And I was telling your bishop that today it is so good to see. It's like a parent, you come and put a seed, and then in the movies they show you time lapse and it has grown. But here is your responsibility. You have fantastic leadership. So I have met a lot of leaders in these 3 years, that vice chancellors, principals, you name it. And Dr. Karthik has such a vast network, and I've spoken to at least 1,000 people on Zoom, in person, and I've been coming very frequently for the last 3 years. So I have met leaders of 3 types. One is who talk a lot, like we talk, and others are who are forward-looking and who walk the talk. I want you to give a special round of applause for your principal. And I'm not afraid to say that. I mean, because it is easy to say. Making this happen is not easy. I'm telling you, even if you have a dinner at home, 6 people are coming, it is an effort. To get this thing going and have these many esteemed speakers to speak to you, what I will say, just listen. Please listen. So I live my life by 3 things: respect, trust and communication. All of us come from a place we respect each other. But respect does not mean agreeing with each other. Respect means giving the courtesy of listening to each other. Trust is something which comes with different people. I live in a place where it's trust but verify. Others are do the trust and it will come back, or I don't trust, and some are conspiracy theorists and they think there is something wrong all the time. But what I would say, the most important part is the next part, communication. You will understand that communication is important in everything, whether you are somebody's sister, daughter, friend, you are going to be part of a team. Communication is going to be the fundamental thing. And also communication in terms of telling your intent to people, your leadership, what you would want. So today we are dealing with this dish. If you swallow it, we'll give you more of it. If you vomit it, then it was a waste of time. So my only request is, please extend the courtesy of listening and take something away from it. And just don't say like, oh, I have to sit for 5 hours to this. There's a lot of content here. And especially you had the young cardiologist, Bhagarat, in the morning speak. I've met him before. As I said, he could be anywhere in the world. But when I spoke to him last time, he said, no, I want to be in Varangal. This is a great place to help young professionals to go there. So, round of applause for such professionals. And I have been instructed by Dr. Karthik, please keep it sharp, because I can go on and on and on. But I want to end this by saying a special round of applause for your bishop, because unless it doesn't come from the top, it doesn't happen. And I'm happy to report that I have got green signal on a lot of other things, and which I don't want to say now, because I don't want to see thunder of other people. So thank you very much. I'm so happy to be here, and we'll be talking. And this is just the beginning of the journey, and this does not end today. We come here and say a few things and go away. Dr. Karthik and I are going to be attached to the hip with you guys in your journey, and more than happy to contribute in your professional growth. Thank you very much.
Thank you very much, sir. We are really gratified to hear from you today.
It's time to invite our chief guest, the most Reverend Father Dr. Udumala Bala, the Bishop of Varangal and Chairman of Father Colombo Institute of Medical Sciences, to share a few words with us.
Very good morning to all. Mera Bharat, come on. Mera Bharat, come on. Hi. Sare jahan se acha hai. I see here a mini India and international Dr. Jay and our Kashmiri born that and US citizen now, and he is there. Today is the age of interconnection through mobiles, smartphone. We are connected to the whole world today, and therefore, born in Kashmir by chance. We are all born by chance in India. By chance, we don't get credit. By choice. And today, if people are asked, student, by choice, what do you want? If in India, I want to go to Kashmir. If in abroad, I want to go to... Yes, sir, international meeting is made, and he is both. Therefore, we want to provide in this Medicare General Hospital students of choice, not chance. By chance we are born, but by choice I want all of you. And I greet very warmly, affectionately, the Tala Padmavati College of Pharmacy, who have arranged this international meeting. And we are national, we are local, but international. We need to be connected. All of you, my dear students, in future, after 20, 30 years, you should be international. Think global and act local. Tell them, think global and act local. Now we are in Varangal. Whatever is necessary for Varangal, we will be doing in pharmacy, clinical pharmacy, I especially greet all the colleges, the principals are here. They are very much honored by your presence, and all the students of different colleges. It's a great thing in Warangal. This is one of the best meetings being held, so we take pride. The Colombo Medical College students are here, and pharmacy students, and also the nursing students. See, we are different categories, but we want, my slogan, my vision for Medicaid Hospital and for the Colombo Medical College, and healthy India, and with you quality medication, healthy India with quality medication, not anything. You know, when I was 40 years ago, father working in the rural forest village, they used to believe that I have a tablet. Anywhere they go, they don't get pure. They come, father has American tablet. What is that? American. Father gives this, anything, any sickness will go. One day, there was a patient who is afraid of even swallowing a tablet. But they brought him and they took, I gave a tablet. He was suffering from 3 years. All the possible sicknesses were there. Then closed his eye and swallowed his tablet. In 15 minutes, he was dancing, talking and all that. So he thought that his tablet worked well. After that we saw the tablet fell down. It didn't go into his pocket at all. So that is the medication is part of it, and your service is the best of it. So especially clinical pharmacy, please, high quality service, and this is, and I say always, medication, health care, doctor's diagnosis, pharmacy students serve the medicine, nurses take care, but it's God who heals. None of these stages there. Doctors diagnose, surgeons cut and open it. You pharmacy students deal the medication, how, when, what, why, and all that. So with your presence, their patients are healed more. The way you serve, also the nurses are there for today. Not only with science of medicine, terribly and terrifically improving. Every day medicine is increasing. If you are not global, you will be outdated. So in your mind, you should be global and acting from the local. So therefore, keep these two words in your minds, and Doctor, that we are very proud of you, that born in India, now serving from again connected. Stage of communication age, sir, as I rightly. Please speak louder, confident. This morning I entered and some greeted us first, others I have to greet, but with low voice, fearful voice. Please no. Please be joyful on your faces and confidence in your voice. Okay, that's the global spirit. And then if you have this communication skill and medical skills, you will become local. Otherwise, you remain local and you will be sublocal. You will become. So with these thoughts, I would like to get connected. All of us, Warangal being connected today, all the colleges under Kakatiya Medical College, Kakatiya University. I thought only these tri-cities. So all over our district under also other districts of Kakatiya, and then the medical students are also here. Let's be united, get connected, interconnected, and your Wi-Fi should be always on. Okay? Wi-Fi of medicine should work and connect you and reconnect. And I especially greet my students, nursing students for the Colombo Nursing College and for the Colombo's Medical College. They are all here. We are the hosts, and we deserve the least pride. First of all, hats off to all of you medical students. You are the best profession you have, and you have a responsibility. God bless you. Thank you.
Thank you very much, sir. We are really blessed by your presence and hear these words from you. Now, we are having small felicitation for our dignitaries on the dais as a token of our respect. Now I request all the dignitaries to felicitate Most Reverend Father Dr. Urumala Bala, the Bishop of Warangal and the Chairman of Father Colombo Institute of Medical Sciences, Warangal. Give a big round of applause. Now I request all the dignitaries on the dais to felicitate Dr. Ashwani Dutt, CEO, Think Roman Venture, United States. Give us a round of applause.
Now I request all the dignitaries to felicitate Sri M. Narayan Reddy, our mentor and chairman of St. Peter's Middle School, Warangal. Please give a big round of applause. Now I request all the dignitaries to felicitate Professor Y. Narasimha Reddy, Dean and Faculty of Pharmaceutical Science, Kakatiya University. Please give a big round of applause. I would like to request all the dignitaries to felicitate Professor B. Mahendra Reddy, Medical Superintendent, Medical General Hospital, Warangal.
I request all the dignitaries to felicitate Professor H. Sandhya Rani Ma'am, Principal, Father Colombo Institute of Medical Sciences, Warangal.
Okay, ma'am.
Director, Medicare General Hospital, Warangal.
Now I request all the dignitaries to felicitate Reverend Father T. Tharu Reddy, Director of Father Colombo Institute of Medical Science. Now I request all the dignitaries to felicitate Dr. Karthik Rakam, CEO and co-founder of Avenida Innovations, Hyderabad.
Now I request all the dignitaries to felicitate Dr. Nazia Anu, Administrative Officer. Please come on to the dais now. Give a big round of applause.
Yes, sir. Okay.
Thank you all the dignitaries for this felicitation.
Our inauguration ceremony ends here and we'll move further with our sessions. So I request Sarayu and Soge to hand over the entry.
నా డిస్ప్లే కొన్ని కావాలి మా డిస్ప్లే కొన్ని కావాలి కాలేజ్ అన్నాడు కదా ఎవరో ప్రిన్సిపల్ సార్.
Welcome back everyone. Myself Sarin from Form 3rd year.
And myself Surya from Form 1st.
We have witnessed remarkable discussions and ideas, and now we are about to enter into a further session on One Planet, One Health, participating in Health Implementation Sciences by Dr. Vijay Yandari sir.
Dr. Vijay Yandari sir is here to share his expertise with us. Let's welcome him with a huge round of applause.
I would like to invite Chairman of the session, Dr. Tala Varun sir, Director of Tala Padmavati Group of Institutions, onto the dais.
I also invite co-chairman Dr. A. Ramesh from Bhavdevi Institute of Pharmaceutical Sciences onto the dais.
TPCP and FCCP and FIDSA, and he has completed his MBBS from Gandhi Medical College, and he is completed his super specialty from Loyola University of Chicago, and he serves as an esteemed advisor to the Ministry of Health, running his technical role resource group of National AIDS Control Organization on Infection Prevention. I am very much welcome to the
Namaskar and good afternoon to all of you. It's already afternoon, I understand. And firstly, let me apologize for not going upstairs on that stage. So for those of you who are wondering, I am paraplegic. I have polyarthritis, so that's why a little bit of adjustment. So I hope you can see me and I hope you can hear me. Right? So I am a clinician and I come mental health school in India and then trained in the United States and worked in the United States. And I also primarily in the area of public health. So a lot of what I will be talking to you is about health in general, not specifically medical care. And the key thing that I'm delighted about to have this opportunity, thanks to the Padmavati Institute of Pharmacy and your medical school, is the opportunity to address all of you young people who have chosen to work in healthcare. This is a very big commitment on your behalf, so I congratulate you. And I know it's a tough fight, there's a lot to learn and not enough time. But I really think that you are in for very exciting times. Things are changing. Sometimes we are afraid of change, but I know that all of you are very talented young people and you should embrace the change. It will be a wonderful life for you. So, one thing I want to say is congratulations on becoming healthcare professionals. The other thing that for those of you who are thinking about the future is here. Artificial intelligence is taking over. Dr. Bhatt will talk to you more about that. But what I want to tell you is that artificial intelligence need not be something that you should fear. It should be something that you should embrace. It will help you. You should control it because that intelligence is artificial. You have the real intelligence. So now let's see what happens when anybody has a problem. Okay? When people have a legal problem, they go to a lawyer. When you have to build a house, you go to an architect. You fix your car, you go to a mechanic. But when people have a health problem, the first thing that they go to is the internet. Google, Dr. Google. After that, they went to the neighbors and relatives. After that, they go to miraculous drinks and ointments. After that, they go to the TV and newspapers. After that, they'll swallow some medications left over from one of the family members. They'll self-medicate. And when all else fails, they'll come to you. Alright? So be prepared for that. This is the other competition that you should really fear. Alright? This is a picture that I took on the road from Hyderabad to Nagar on the highway, the Bangalore highway. And I was very curious. I stopped to see them. And what is amazing is that you can't see them in future. We'll have to shut down the lights for you to see it. But they have all sorts of problems that they can address. Okay? Now, amazingly, this is not a one-person mom and pop show. This particular clinic happens to be part of a big chain. out there. Right? This is another chain, Sigma, and look at all of the different pharmaceutical agents that they've got lined up. They can cure anything, believe me. Right? So, if you ever despair of the things that you've been taught in medical school and pharmacy school, there's another alternative for you. Now, you are all being told that it is an important profession that you have entered. Right? But this is what George Bernard Shaw said through one of his characters in the play, The Doctor's Dilemma, from the early 1900s. It says, all professions are a conspiracy against the laity, which means that, that all professionals do is mystify their trade by all sorts of jargon. They tell the patient, you have got this very incredibly difficult medical problem that is going to be extremely troublesome, all right? And they'll give it a very fancy name like colonic motility disorder, which I call constipation. So this is what happens, all right? So you want to understand why George Bernard Shaw said that all professions are a conspiracy against the laity. Now, traditional healthcare. Now, what is traditional healthcare? And unfortunately, here I am going to be a little critical of the orthodox way of teaching that goes on in our medical schools, including your own medical school. You are taught anatomy, physiology, biochemistry, pathology, and so on and so forth. This is what we call the pathology paradigm. You're always looking at a human being in front of you, trying to figure out what is wrong, what needs to be fixed, what medicine to give, what to cut out, and so on and so forth. It is analogous to looking at a malfunctioning machine, where you are going to look at what part is defective, how you're going to repair that part or replace that part. Now the problem is that because of this particular approach, medicine has become fragmented, compartmentalized. There are cardiologists who take care of only the heart. There are nephrologists who take care of only the kidney. There are pulmonologists who take care of only the lungs. The gastroenterologists take care of only the gut, and so on and so forth. And in this process, what everybody has glossed over is that all of these are parts of the same human body. And I can tell you very often, I come across patients who have been prescribed conflicting medical regimens by different specialists. The cardiologist is using drugs that the nephrologist says, oops, that's too dangerous for you. The nephrologist then uses drugs that the endocrinologist says, no, you cannot do that. The rheumatologist uses drugs that I, as an infectious disease clinician, says, oh, by the way, those drugs are going to cause infections in your patient. So this is what happens. This is the modern traditional healthcare. It looks at people as malfunctioning machines and then subjects them to fragmented medical care inside very high-tech institutions that we call hospitals. It's expensive, and very often it ends up hurting the patient rather than fixing the patient. Now, think about it. If you had a vehicle that was malfunctioning, and you took it to your mechanic, and the mechanic could not figure out what was wrong with the vehicle, and in the process of trying to repair the vehicle, actually caused more damage and made the vehicle almost unusable, and then presented you with a big fat bill. How many of you would go back to that mechanic again? Raise your hands. No? And that's what happens in traditional medical care. Patients go to the hospital. People completely forget about what they are complaining about. It doesn't really matter. You cardiologist is going to discover a need to do a coronary angiogram and put in a stent before you can say anything. That's what medical care has become, right? So, this is, the reason this happens is, it is the medicalized paradigm of pathology, right? So what's better? Now, what I have come to now embrace is Aaron Antonovsky's concept of salutogenesis, which says that we must look at each and every individual to understand how that individual has better health. And I often do this to my colleagues. I say, you are trained in a model of pathogenesis. And I'm here standing in front of you. Look at me and tell me, am I well or am I sick? Am I full of pathogens? Then you will see all of my colleagues squirming in their seats, embarrassed, and they don't want to look at me. Okay. But if you use the salutogenesis model, which says that what we need to think about is how do you help somebody have a purposeful life with autonomy and dignity. And as long as I can meet the needs of my life, then I am in good health. I am in health ease. And the converse is dis-ease. So you don't look at anybody trying to figure out what's wrong. What you want to do is look at somebody and say, how can we work together with a shared vision so you have a better life? What's a better life? For everybody it's going to be different. What I enjoy is something that my wife doesn't necessarily enjoy. So she told me, you go to India, I'm sitting in the United States. All right? So, it's all right. That's your life, this is my life. So, what is a purposeful life? It's going to be different for everybody. But every life has a purpose. And that's the key thing to understand. Don't look down upon your patient condescendingly with pity in your eyes. Look at your individual patient in front of you as your partner, with whom you are going to build a shared vision or a purposeful life for your autonomy. And you will find, as I have in my own life, very often, even when I think that I am there to help, it's actually my patient who is helping. Like inspired me over lives. I started my early career taking care of people with cystic fibrosis. Young people with a fatal illness. They came to me for a lung transplant. Without a lung transplant, they would not have life. And what was amazing to me is they came to me with complete equanimity. They were everything. And by the way, if you think today's patients are reading Google, they read everything. They read the literature, they knew everything about cystic fibrosis. They knew more than I did about cystic fibrosis. And all I could do was just be absolutely amazed at that indomitable spirit that they had, that they were prevail and conquer. And they went through lung transplant. And they went through it. I will tell you, I was flabbergasted when I saw in the intensive care unit a cystic fibrosis patient, 6 hours after 2 lungs were replaced, walking around with her own plate of food in the intensive care. And that's how I spirit is what you should work, not the alcoholic spirits. So what salutogenesis says is that what we need to do is create an enduring partnership in a sense of coherence, comprehension, a clear understanding of capacity and ability to cope with the health condition, and capability and ability to pursue a purposeful life with autonomy. That's what cellular fitness is all about. And one health and one planet is nothing but extending the concept of cellular genesis from the individual to the family. Remember, every individual is a constituent member of a family. Every family is a constituent member of a community, and communities are a constituent member of society at large. So once you start saying that I am going to start working to have everybody have a purposeful life of autonomy and dignity, that's what translates into one health and one planet at a population level. So let's see how we do that. Now this is what I call a health empowerment instrument. Yeah. Believe me, one delusion that you should shed, which unfortunately a lot of our training has imparted to us, is this delusion that we actually cure people. Nothing of that sort. You heard Reverend Father Bala say that it is God who heals. We are merely His instruments. Right? But very often I find healthcare professionals instructing their patients. Trust me, I'm a doctor, this is what's wrong with you, this is what you should get. So I see patients day in and day out, and they are coming to me with a whole stack of investigations and a whole bunch of medications that they are taking. And I ask them, why did you do this? Oh, my doctor told me. Why are you taking these medications? Do you know what these are? No, I don't. I'm taking it because my doctor told me. So what I have now done, after 35 years of trying to train healthcare professionals and failing, is going to the people directly, the patients, and telling them that they must empower themselves. So this is what I call an instrument of empowerment. Ask your healthcare professional some very pertinent questions. Ask, what is the diagnosis and what is the health condition that I have, right? In language that I can understand. It doesn't have to be loaded up with all sorts of jargon. It's easier to explain to somebody what is constipation than to tell them they have a colonic motility disorder. If you tell somebody they have a colonic motility disorder, the actual disorder is in your intellect, not in the patient. Right? Explain the exact reason for any kind of testing and cost implications. If any medication is prescribed, have your provider explain what is the reason for the medication, what is the chemical name, how does it work, how long does the medication last in my body, how is the medication eliminated by the body, what are the 3 most troublesome side effects of the medication, what side effects are possible if combined with any other medication. How do I know whether I'm benefiting or suffering from side effects? What will help me prevent illness in the future? Vaccines, diet, exercise. What can I do to help my family with their health? And what is one health and one planet? Okay. Now, for those who are in pharmacy, will recognize I've been asking about absorption, distribution, metabolism, elimination. Now, I guarantee you go and survey all the practicing doctors out there, all the doctors who are out in practice, and see their prescriptions that they are writing, and ask them, doctor, what is the pharmacological name of this medication you wrote down, and what is the AD&E? And I will tell you the response that I get from most of my trainings, and I've been training healthcare professionals for 35 years. So the response that I typically get from them when I ask, tell me the AD&E of this drug, the response usually is, okay? Now don't you think that is dishonest? If you yourself don't know what you're doing, how can you expect your patient to trust in your ability or your effort to actually help them? Alright? So this is what I call an empowerment instrument. And trust me, a lot of people are now beginning to understand. People are not dummies. They can go onto the internet and read everything. Okay? And they will come to you and say, Doctor, prescribe this drug for me, and I'm having the side effects. You can tell me about this. You are not a good doctor. Don't be surprised if they say that to you. So, one of the instruments that we started thinking about is how to convert an abstract concept of one health, one planet into something that will actually work, and work with people, lay people, not professionals. So that's what we call a health advancement, peer partners, empowerment, So HAPPEN is a framework of participatory action research. What it says is that it's not just the healthcare professional who can decide what the goals and metrics of any intervention are. The people that are part of that entire enterprise are equal partners. They will decide as much as I will what kind of research is done, how it is done, and how we measure its impact. What that means is that we have to sit down together with our patients, our families, our communities, and build a shared vision along with them. Only then and only then can we think about improving health. Networking is very, very important. It is an inclusive network because think about it. Who does anybody trust? If you had a very important decision to make in your own personal life, whether it's marriage or what you name your child, or what kind of place you're going to stay in or live in, or what kind of vacation you are going to go on, or what kind of vehicle you want to buy, who do you go out and ask for advice? Do you go out on the street and grab some random person and say, hey, I need you to give me advice about this very important thing in my life? Or do you go to somebody that you really trust, your friend, your family member, and so on and so forth? So if we want our people to trust us to be their navigators for good health, the first thing that we need to do is build a relationship of trust with them. So we need to go out to them, introduce ourselves to them, and make friends with them. Let them know you know them. And I'm so heartened that now in India, a lot of medical schools have started this process of every medical student right from day one adopting certain families and following those families throughout their entire training. That's what builds trust. If you know somebody, it's easier to trust them. And trust is a two-way street that we need to work very hard at building. So, the Mike-Church model is one thing that I would ask you all to think about. What is a Mike-Church model? What the Mike-Church model says is that every individual is born with certain attributes. And as they grow older, they acquire certain other attributes. Education, they grow taller, stronger, more muscle, every which way. They also grow more beautiful, so they can attract the other gender and so on and so forth, right? And along with this, what happens is now you are interacting with the rest of the environment, the society at large, the environment at large, many different social factors, economic factors, and so on and so forth. All of these put together are what decide whether or not you are able to meet the demands of your life. Like I told you, I'm a paraplegic. I have found a way to use braces and crutches to go about everywhere that I can go about and practice medicine. So I'm perfectly able to meet the demands of my life, and therefore I can help ease. So adopting the Mike-Church model both at an individual level and at a community level and at society at large is something that we need to think about. How do we help people? Even people who have severe disorders can contribute a great deal to society. If you think about their strengths rather than their weaknesses. That's what the Mike-Church model is all about. So we talked about the biological potential, this is what you're born with. We talked about the acquired potential, this is what you get from your nurture, your education. again, what we need to think about is once we are interacting with the entire environment, this is a complex adaptive system. There are no simple answers in life. Everything is not an action and reaction. When you think about talking to anybody, please understand that you need to pay attention not only to the biologic attributes that you are examining, the heart rate, the pulse rate, the lung exam, the blood pressure, and so on and so forth, but you need to pay attention to their social background. What kind of family do they come from? What kind of culture do they come from? What is their education level? What is their income level? And most importantly, spend a little time trying to understand what their goals in life are. What is their particular perspective on health? What do they want to do? What is their definition of health? What is their definition of purpose in life? And that's how you build a perspective on that. Appreciative inquiry. So I would ask all of you to think a lot about using techniques of looking at all the good things rather than just the bad things. Okay? Again, what we say is take the problem and convert it into a positive or desired result. Finally, a global assessment. We've got to put everything together and think about what will happen. I just want to give you one slide about thinking about the one planet concept, where environment comes in. Air pollution, inadequate water, chemicals, radiation, community noise, artificial risk, agricultural practice, climate change. So ask your patients about all of these things. Now, one very important thing is animals. Most infections that occur in human beings are actually zoonosis. One of the most common illnesses in India is rabies. Okay? So what we did one time is we just went out to a bunch of villages and we asked how many dogs there are there, how many pet dogs, how many stray dogs, and how many dog bites there are. And what we found was something very interesting. A lot of pet dogs, a lot of stray dogs. And when we mapped all of them, when we looked at where dogs congregate, they congregate where there is a lot of litter and garbage. So we create the problem ourselves by fouling up our environment, creating a lot of dogs, and then the dogs bite our children, and then we get a fatal illness called rabies. So this is the importance of understanding the impact of the environment, animals, humans, all put together in one health and one planet. So I'm going to stop here, and thank you all very much for your attention.
Thank you so much, sir, for your beautiful presentation. We are grateful for your knowledge shared with us today.
I would request chairman of the session to give his feedback.
First of all, I thank you, Dr. Vijay and Reddy, for speaking about the way facts of the journey of medicines from the research to the patients, as well as health professionals' contribution for the development of patients, as well as sensitizing all young healthcare professionals about the development of medical profession as well as education. Thank you so much, sir. We are delighted by listening to your great session. Now it is open for audience. Any questions? If there is no questions, please give a round of applause for the Vijay for his presence in Talapadmavati College as well as Colombo Medical College.
Thank you, sir. I request Dr. Ramesh sir and Dr. Raghunandan sir to felicitate Dr. Vijay. I request Dr. Vijay and Dr. Raghuvanathan sir to felicitate Dr. Ramesh sir.
Ada
anak.
Ada ini?
I also request Dr. Vijay and Dr. Ramesh to felicitate Dr. Raghuvanathan.
Lagan ada project.
Okay, sir.
ఒక్కసారి
Now,
Clarity
get ready to delve into our next session. We have exceptional line of speakers waiting to share their expertise. So, let us eagerly embark on this next phase of our conference journey.
Focusing పోయిందా?
ఫోకస్ పైన ఒక్కసారి.
With a great pleasure, I invite Dr. Ashwani Dar, CEO of Technoman Ventures, USA on the topic Artificial Intelligence in Healthcare and Healthcare Technologies Leadership. Onto the dais, we can do short of applause.
I would like to invite Chairman of this session, Dr. Tala Varun sir, Director of Tala Padmavati. I request Dr. Praveen sir, HOD from St. Peter's Institute of Pharmaceutical Sciences, onto the dais. I request Ashwani Das sir to come onto the dais.
Yeah, I'm here, don't worry, I didn't run away. So what I did, I wanted to see who are sitting in the back benches. And what did I find? All medical students are sitting in the back bench. And I don't know how many of you know that I'm a doctor also. So I'm going to, they're doing anatomy and I'm going to ask them the dissection they have done recently. Where is biceps muscle, the insertion, and the nerve supply. I'm not going to talk artificial intelligence because that's not going to help you to identify tomorrow you become a surgeon and you have a bleeder, you need to know the anatomy. Unless you don't know the anatomy, you don't know what forceps and where to catch the bleeder. AI will not tell you that. Or will it? What do you think? It will? No, it might. So what we are going to do is talk a little about AI. So first let's try to see who is in town. All of the medical students stand up. Okay. So those are the usual culprits. So they want to be there but don't want to be there. Like you have been bought like under you have come of free will or free will? Yes, you came by your own free will or you had to come? Had to come? Yeah, I like at least you're honest about it. Okay, sit down. What about the pharmacy people? Who are pharmacy students? Please, stand up. Now, medical students, a round of applause for them. You know why? Because they are going to be one day saving your life. Because most of you would not know what the salt in the medicine is. They are going to tell you what the adverse event is going to be. Please sit down. So I'm going to be talking about artificial intelligence. And if you want to listen to me, then you will have to be quiet. If you want to talk, I'm not going to be there. I'm a town hall guy. I will come and grab you by your throat. Why are you not listening to me? Okay, I'm not your like nanny kind of person. I'll make you listen to me. No, I'm not bored. You are intimidated. Who is this guy? So, artificial intelligence by itself, the name, is kind of a bit misleading. I want to call it augmented intelligence. So, I would see some of the people who have come to watch animal movie that means most of you have watched standalone learning. So I'm not going to talk Bollywood, Hollywood, and though I do, if any one of you has people in movie business, I'm looking for a villain role in a Telugu movie. So if you can get me one, I won't charge anything, free. I have asked Dr. Karthik so many times. He said, you don't have hair. I said, we can put a wig, it's not a problem. He said, then I might talk to someone. So going back to artificial intelligence or AI, I would rather call it augmented intelligence. Yeah, I'm a very, very strict guy. So don't go by my good looks. So one of the things I think I said in the morning is respect means extending the courtesy of listening to someone. Then you can say that was BS. What is it? I know that already. And I'm going to tell you that I'm not going to tell you anything new, which you have not heard, but you will hear it in my voice and it will make a difference. You know? So you might be thinking this guy is full of himself already, so why are we listening? Because there are a lot of new concepts which you might have an idea of, but don't know what their capability is. So let's kind of do one thing. How many of you know about ChatGPT? Raise your hands. You don't know what ChatGPT is? Which rock do you live under? You don't know ChatGPT? I need to take a video of you and send it to United States of America, to Zuckerberg, Elon Musk, and tell them, hey, there are people, there's business out there, they don't even know what ChatGPT is. So ChatGPT is an open AI, an artificial intelligence platform, and it can do a lot of things. And I'm not here to sell their services. Similarly, Google has an artificial intelligence engine called BARD, BARD. How many of you know BARD? 6 and 7 people. And one is our own paid person, Dr. Pranay, who's manager at Avenue. So you guys don't know what ChatGPT is? So then I am going to tell you something which you don't know. So thank you and round of applause for that. Because otherwise they have good website. So that is good thing. So how do you
Satish.
Yeah. So I will tell you why I put in my picture there. Of course, none that I'm narcissistic. I believe care has to be patient-centric. And technology has to enable doing that portion. And I was talking to somebody in the morning, the patient engagement is so minimal. And you know, COVID was a bad thing, but out of that adversity, one thing came about, that is technology and people's engagement in their health. So I'm a firm believer that people should be participating in their healthcare for better health outcomes, and technology should be the vehicle which helps. So I'm part of Avenida, Dr. Karthik is a part of Avenida, and we are, if you were to ask us what is our DNA, our DNA is to be the bridge between where you are and where you want to be, both for the pharmacy people and medical people. I don't have any differentiation between the two. You for me both are healthcare providers. It is a care team which you are a part of. And if you don't think of that, you as a part of that, you are not going to be successful. So I'm also part of USA, a part of Cardiogenics. It's a medical device company. So we are making, think about AirPod at least, AirPod. Raise your hand at least, I need to get some satisfaction. Who knows AirPod? Okay. So AirPods are small, good with headphone. So the size of that we are creating, which sets so it sits on a think of a disposable bandage, and it sends wirelessly 6-lead ECG, SpO2, your activity level, toughness, blood pressure by this. So you will see a patient, you medical students, you will see a patient now in WhatsApp and do a teleconference or telehealth and see their ECG in real time. All you need is an internet address. So that is what we are doing. And those of you who have money hidden under your tree or something, family, give it to us. We are raising funds for that. So we are pre-FDA company, and that's the medical device. I'm also an advisor at the UCSF Health Hub, where I mentor young CEOs who are coming to the health industry. I try to set up their own companies. And then Think Global Ventures is a kind of a consortium of things under which we have software development. I'll show you those of you who like to write something. We have online health magazine and also another magazine where you can do like a short story or something. We will introduce these to you and you can download those apps. You want to write about healthcare. We don't need to have an obligation. You want to write about healthcare. You're more than welcome. We're going to open all of that. So, what is the healthcare landscape today? So, there are so many challenges, and challenges are so multifactorial depending on which part of the world you live in. Mostly it's the cost, there's the access, and also in those places, I think India is still kind of at the vortex. Because India is lucky to have the largest young population. But in the Western world, especially Europe and America, we have an aging population who are called baby boomers. And their access to healthcare is so dependent on insurance and all. So what all it demands is we have to have innovative solutions. How do we provide healthcare? And AI can be one of those things. And again, AI is not going to replace this, but it is going to augment and help us. So, why AI is helpful? Because ultimately a lot of things in healthcare are data. You're looking at an Excel patient, it's data. Like you want to see is there I don't know if you understand what I'm saying today, there's just students. You have a consolidation in the right plan, is it pneumonia or not? So, if a human eye as a radiologist 5 X-ray and then determine, we can throw a million of these images at a model which you must have often heard of as ML means what? You don't know. So, you train the model so that it can make a differentiation that this is the image of a pneumonia and this is not. And then you can create an algorithm. Algorithm is just nothing, it is an if-when conditionality. If this is present, that means this is the thing. And you can also use it for pathology. You will take a smear of blood or a tissue sample or a biopsy, you need to look under a microscope and make a determination. It is a data point. So you can have 1 million slides and do ML on it, and ML, by the way, means machine learning. So for those of you who are strategy and so basically, you're training the computer. Let's keep it in a very simple language. You want animal or which movie? Animal movie or Sam Barber? Which one? This is a movie. Which one? Which movie have you come to watch? Okay, can you figure out Sigal movie? Oh, he's not this. So, why don't you go and call him, please? So Prateek, you saw something in action. So pathology is a great place, and some of the places now you have medicine, you have a hospital system which you are, and in 5 years you have 1 million slides of biopsies of people. Now you just see and send it, machine learn the thing and take the deduction that, oh, this and this thing is there, it was automatic. So just taking away the accuracy, you should think a bit about it. What is the accuracy of diagnosis for radiology and pathology using AI and machine learning? It is mind-boggling. So even at our small level, think globally, where we are a small printing company, we have an ML engineer who has created a model. If you put an Excel test, it will tell you if it's pneumonia. So think about what big companies like OpenAI and Microsoft and others do. So that is the diagnosis part. It can also take care of the administrative tasks. Let us say a simple task. You are 6 physicians working in a group and the radiologist, cardiologist, nephrologist and all. Patient presents to the system, right? While they are presenting to it, the system can automatically say should be seen by the nephrologist. So it would automate a lot of administrative processes, and then the process of who saw who and maintaining. So today I think at our pre-normal level, if you give me a doctor's notes, I can tell you what the diagnosis is. I don't need to ask for this, because if you look at elements in families and present elements, chief complaint, present history present illness, I don't know whether you know what a soap node means, soap which you. So look at what soap node means. And it also can improve patient care through personalized treatment plan. So you could take a data point that this is the demographic details of the patient. These are the people in that population with that demographic and that diagnosis. You can then create personalized treatment plans. I'm not talking of pharmacogenomics, which is a different branch. This is just data driven. So, in fact, it created a problem in the US at one time because it was from a data analysis, it was predicted by association that certain inotropic drugs and some other medications, the beta blockers, were more effective in American black population, and they were given those medicines. They were very, like cheap medicine, metoprolol and others. Then the black community said, oh, they are taking us with cheaper drugs. No, that was really that big. So data can help to drive the treatment as well. And data can also predict what is coming along in the crisis. So what are the different types of AI in healthcare? So you can have different applications. You can, as I already said, you can have machine learning. You throw, and I said throw, you don't throw. I mean in the metaphor. You have a big data, a body of data. You take associations out of that, and the computer can go through that, and when it sees that again, it says this is this because the data was connected in such a way. And how many of you have heard a thing called NLP? That's called natural language processing. Basically, if you put a mountain of text into a computer, it can find out. So you medical think what it could do. If you have 20 patients and you are taking, they have filled in there why they are coming to you, what is their family history, what medicine they are taking, it will automatically analyze that and say, oh, your differential diagnosis you should be thinking about is this, because the patient is diabetic, because blood sugar is this, and it will say there is some renal problem also, because serum creatinine. So it can do those analysis. And the other branch which you will get to know and you should read about it as you go to general surgery and all, is called robotics. You know that we are doing anatomy, we just started at the upper limb. So when you go to the abdomen and all, you see on the photos it looks very easy. This is intestine and this is peritoneum. But once you do, I have done general surgery in my medical practice for some time. Then the momentum does not look like that in the picture. So it looks very different, and some of the anatomy has a very difficult access. So robotics is that where these machines can be controlled in person or remotely through a surgery. So Da Vinci is a machine. If you look it up, you write something, you know it. You should look up. So that is already being used in a lot of centers in India also. So I already talked about radiology and pathology. In radiology and pathology, the level to which you can fine-tune the diagnosis and the precision of diagnosis is mind-boggling. When I tell you mind-boggling, you should Google that what is the accuracy of AI in diagnosis of radiology as compared to the human eye. You will say, wow, I didn't know that. And it's real. I've seen it in action myself. There are some very large health systems. Because your ML and AI is as good as how it is trained, how much of data it has been trained on. And if you are a health system, you have a large body of data, you can train the system to give you better accuracy. Similarly for pathology, AI in pathology is so helpful. You know, you had a lot of these biopsies sent to, whether it was a liquid biopsy or a biopsy sent to, they would say, cannot come because the human eye cannot interact, kind of intercept and recognize patterns which AI can. So the accuracy of diagnosis is very, very high in radiology and pathology. So the other thing is when you're setting up a treatment, you can create a machine learning model that you say that if a patient is in heart failure, this is the medication which has better results. And based on that, you can also create analytics, which is called predictive analytics. Let me set it up. You have 5 patients in a hospital, all the 5 have congestive heart failure. Today, we have a capability to create a risk analysis that how many of these will be readmitted to the hospital within 30 days. What is called as a readmission score. Similarly, you can today, with AI, predict how many of the patients brought to your ER or casualty or emergency will have sepsis. Because it's not doing any magic, it's just taking the blood count and lactic acid and making an algorithm. If a patient comes in and fits into that, it will say the chances of this patient going to sepsis are 60%. And then you will build on it that when, if wet condition that if this is present, then issue these orders, you automatically order and do this, put this and that. So treatment through AI can be very, very life-saving at times. You know that if a patient goes into sepsis and you are able to predict in time, you can save a life. Similarly, I don't want to tell you the importance of such things in evolving stroke. The patient is about to go into stroke or a DIA, which is transient ischemic attack. So you can use AI in diagnosing them. And in terms of radiation therapy and all, AI can calculate the doses, the area where drugs are discovered. The molecule is decided on to be worked on. And then you have a data set called clinical trials, stage 3 and so on. And off of that data, you can help to have drug discovery done faster than just computing it manually and ADR and all. So drug discovery in AI has been very, very fast tracked because you can predict how a molecule is going to interact with the human body based on the data. You must have seen in movies or sci-fi fiction, they show these molecules and heart. So that's real. That is real. So you can simulate models based upon how a cell or body tissue would react to a certain molecule. And I told you about the predictive analytics of you can predict the readmissions of a patient. Similarly, you could today, if you have the models of COVID-19, predict when there could be a pandemic. So, but the problem of AI is you have to have good data. Otherwise, it is, I don't want to use this, but this is true, garbage in is garbage out. If you have low quality data, then the prediction based on the low quality is going to be low quality because the quality of the data was not good. So when you start saying, yeah, we have data, how good is the quality of data? So we have Dr. Pradeep here, who is part of another company which does clinical trials and all, and he's a data analyst as well. So he will tell you that he will agree with me that the quality of data. Pradeep, you want to stand and say hi to everyone? So this is Dr. Pradeep. So round of applause for him. So now I am a health system. I can predict my patient population who are going to get admitted. So let's walk this. Now look at the ramifications. I can predict that I am going to have these many patients of pneumonia because winter month or whatever. And then these are the diagnoses. I can take that and see I need to have these medications already stocked. I need to have this much of staff because I will have this. So it has a ripple effect of efficiency and managing the resources. So you can do resource allocation in healthcare facilities. So that's why you see some of these big health systems are more efficient because they have these tools which they use. That's what differentiates them from the other health systems. Because they understand that the allocation of their resources can be done better if they use predictive analytics, which is based on AI. So we have done our contribution to it. How many of you have phones? So take out the phone. And focus on the screen and scan the code. So you don't have a phone?
ఒక 2-3 స్లైడ్స్ స్పీడ్ గురించి
So how do you say? You heard your principal. So quickly do that. Do the scan. I'll give you 2 minutes. And I have Dr. Pranay. He is also distributing pamphlet which has a. And those of you who are, I know the network might not be good. So those of you who are able to download it, it's my gift to you today. Today is your lucky day. Happy birthday. So you can have AI-based health insight in your pocket. And you know those aunties and uncles for the first year students who think that you have already become doctor and say, I have this, I have give them this application. Because now they can put in this, I have a pain right knee and this will sort answer. You don't have one? You want one? They didn't buy one for you? No, that good. So I have a first year medical student here who has left her phone in a locker so she could attend to this lecture with her. So a round of applause for her. Please stand up. So that is, I have first time seen somebody do that. So how many of you have been able to download it? So raise your hand. Illa? No? So, you are going to throw it away? Just do the same. You have a phone, right? Okay, medical students, you download this is real free gift for you. No network, yeah? Okay, take this, but you will love it. And give it to all those nagging uncles, aunts who think you already a doctor. You just know first page of anatomy, right? So what else are you reading? Physiology? Anatomy, physiology? Biochem, okay, how many of you like biochemistry? I want to see that person and give them a Nobel Prize. Okay, at least you're honest about it. And biochem some people do very well. I don't think it was biased counsel. So start telling it that you have both. Google as well as both. Okay, I just wanted to say that both Google people, Android people as well as Apple people can download it. It's available in both this file. Okay, so
paper photo.
So let's I've been told that I should start winding up the show. So these are the benefits of the AI, and this is just the start of a conversation. Please look up other things. I just wanted to make people aware that AI and other things are good, but there are some challenges. So data privacy, regulatory and ethics. So ethical considerations. So this will always be a challenge in AI, that what is ethical and all. As you get to know more, you will understand the privacy issues and ethical issues of using AI. So I also wanted to make you aware, so AI is something and then there is quantum computing. I don't want to bore you with the technical. So you already got this. Use it, it's a good tool. So, I don't know you're interested in my vision, you can read it, I'm not going to read for you. I want that it should enable us to have better outcomes for the patient. Because in all our pursuit, we sometimes forget, ultimately it's about the patient. It is about that transaction between the provider and the patient. It can be collaboration research. So AI is transformative. You just have to be careful about the boundaries, and those are regulatory, ethical, and how does it work in the environment where you are. So thanks, and this is the time to applaud. So I want 1 minute of your attention and then I'll let you. So I want you to take this as a starter idea. I will tell you at your age, I want you to be two things. I want you to be curious and fearless. Fearless does not mean you're going to box people outside, but be curious. And you are in the medical field, unless you're not curious, you will not be able to help your patient. So thank you once again for listening to me, and I look forward to working with you as a group, as a team, and I wish you all the best in your professional journey. Thank you. No, you did not. So did you like the rest?
Thank you, sir, for your enlightening and engaging presentation. Your presentation has been added immense value to your conference.
I request Dr. Ravi to give his feedback on the session.
That's a wonderful thing, Dr. Ashwini, and one of the core areas which even faculty also looks at as AI in healthcare, and it's a good professional review, and special appreciation to Javier for listening for this program. Thank you, sir.
ఆయన మొత్తం సరౌండింగ్ మొత్తం సరౌండింగ్ మొత్తం
Everybody, we are having a lunch break for 45 minutes and the assembly here by 2 o'clock. We are having 4 more important sessions. That's on hands-on training.
I request Dr. Ashwini and Dr. Mahendra to participate in the same conversation.
సాయంత్రం వరకు ఉంటుంది వచ్చాను వాష్రూమ్ కనిపోయాను నాకు దొరకలేదు చికాకు లేచి అంత చిక్కులు వేసారు ఎంత మొత్తం వచ్చాను
మేడం మాట్లాడారు, సుధీర్ సార్ మాట్లాడారు, అయిపోయింది. గీతికా మేడం లేదు, పోయింది. గీతికా మేడం లేదు, పోయింది. హలో సరియా चालू केस ना बरोबर आता జరిగే అదే మంచి కనబడుతుంది అటు పోతాను ఇటు పోతాను Okay, sir.
చూసుకో మరి ఎక్కడ పెట్టేసి అది కూడా ఉంది కదా.
So he has completed his MBBS from the JSS College itself, and he is to get concentrated in the maximum background of clinical and industries domain. And Dr. Subhadra is a very high valuable knowledge in the pharmacovigilance as well as the medical appointment. And at present, he is to get getting in a very high position, like the director of medical affairs and Oxford Life Sciences Private Limited. Maybe he is having a very good capacity under Oxford Life Sciences, especially he is to get concentrated in medical function, like the steering of the various activities, hiring of the individual students and subject matters, along with the help of expertise, business, development process, along with the help of various enhancement conditions and trainings, audit programs, and various inspections. I'm requesting Dr. Muhammad Subhadra, please present this session, sir.
Give me.
So a very good afternoon and all. I know it's a tough session, especially the one which is after the lunch. So we have that post-prandial somnolence. So how many of you are not feeling sleepy? Oh, that's a huge number, but I can see some hands which are not raised. So we do have some people who are, Okay. So I would like to thank the organizers for giving me an opportunity to speak in this conference, and yes, thank you sir for the generous details about what I do and my credentials. Thank you so much for that. So dear friends, I'm going to speak on risk management of medicinal products. So it is a very essential step you come across in the pharmaceutical industry. So before I proceed, Sure. So I think by now everybody is aware of what exactly is pharmacovigilance. If you don't know the exact definition, at least you would be aware that it is something to do with detecting, analyzing, and prevention of adverse effects of medicinal products. Right. So everybody is aware of this. Yes. So is pharmacovigilance necessary? How many says thumbs up? Very few. How many says thumbs down? Okay, you have the third option also. So that is I don't care. very necessary step. Okay, so I'll go back to my previous slide. So we have told that it is about detecting, assessing, understanding, and prevention of adverse effects. So I want to concentrate on this particular term, prevention. So at least when I was a student, when I was doing my MBBS and MD, we did not have this. Pharmacovigilance was still in that budding stage. It was not given much focus on, and then we had the basic understanding was it's about reporting any side effects to pharmacovigilance program of India, and if there is anything which is related, so probably we would run across to get it published. So one essential element which we miss out is on the prevention of adverse effects. So it is something which is very important. We are in a stage where we should ideally aim for a situation where we don't have any adverse effects. So I know it is very, it cannot be absolute, but yes, to a large extent, to a maximum extent, we have to make sure that we are able to prevent the side effects. So before I delve deeper into the topic, so any pharmaceutical product can be associated with the side effects. So let it be any drug which is there in the market, however safe it may be. So paracetamol, how many of you think it is a safe drug? Yes? Come on, raise your hands. How many of you think it is a safe drug? Aspirin. Obviously, in a relative state, these are safe drugs. But when we are doing signal analysis or what we say, try to identify any new information pertaining to any particular drug, we do come across some safety information which is new, which has not been identified yet, even for paracetamol, even for aspirin. So all these drugs which are there in the market, supposedly which are actually very safe, can as well have some life-threatening and fatal adverse events. So paracetamol, it can cause Stevens-Johnson syndrome, toxic epidermolysis. I think recently you have heard in news that mefaminic acid meftal is associated with some serious contagious adverse reactions. So these drugs have been there in the market from long. So new things keep coming upon identification. Okay. So there is a concept called as risk in pharmaceutical industry. So what is a risk? So it's basically an untoward clinical outcome. So any medicine might have a risk associated with it. So us pharmaceutical physicians, the medics who are involved in, or pharmacovigilance professionals would be, for some of you might join pharmacovigilance. So it is our responsibility to identify such risks, identify anything, any missing information is there pertaining to any specific drug, propose a strategy to mitigate those risks. Okay, we come to different case scenarios later, and also check whether these risk minimization strategies which we have proposed are actually working or not. Okay. So until now, is it clear? Any questions pertaining to this? Okay, fine. So this is a brief flow chart about how we go about the risk management process. We identify the risk, we check whether it is important or not, we look for any missing information, and then we try to propose and implement risk minimization strategy, and subsequently we also check whether this particular risk minimization strategy is working or not. If it is not working, we have to go back, re-strategize, propose a new strategy. So as I said, any drug is not safe. So it will have some inherent risks which are associated with it. Let it be paracetamol, let it be aspirin, which is, these are the drugs which are commonly used. Okay. So in pharmaceutical industry, you will hear of terms called as benefit risk profile of the drug. So we have to maintain a favorable benefit risk profile for a pharmaceutical product. I mean, just by extrapolation, it also extends to the vaccines, biologics, so on and so forth. So what do you understand by the term benefit risk? A favorable benefit risk. So let me put it up in one sentence. So a pharmaceutical product should be consumed, should be taken only when the potential benefits outweigh the potential risk to the patient. Okay. So So you are getting benefit out of it, but yes, there are some risks which are associated with it. But the benefits which you are deriving from using the medication can actually be they far outweigh the risks which are associated with it. So I come across this situation often where people say they are newly diagnosed with hypertension or diabetes. So I see this misconception a lot. So they come and say that, doctor, we don't want to take anti-diabetic medication or antihypertensive because we'll become used to it, we have to keep on taking it. It is not about that. So by taking that particular medication, you are getting your blood pressure under control, you are getting the sugar values under control. So if you don't consume that, the disease is far more dangerous. The harms which you will suffer because of not consuming the medication will be higher when compared to when you are taking that particular medication and getting your sugar and blood pressure under control. So everybody agree with this concept? Yes. So next time, if somebody asks you, you have to tell them. So if you don't take the medicine, the disease is going to harm you more when you take the medicine, right? Okay. So as we discussed, new risks keep on emerging at any given point of time. Okay. So recently we have seen about mefaminic acid. There was a circular from TPCP focused that it is associated with Stevens syndrome, if I'm not wrong. So we keep using the drug in a large group of population. So they might show a different response. There might be some genetic, rare genetic, makeup of few individuals. We'll come to another case scenario later in my presentation. So that can be associated with untoward reaction, idiosyncratic reactions can take place. Okay. So not that important, but yes, we know that what is the risk. Risk is basically an undesired clinical outcome. In pharmaceutical terms, we divide them into identified risk, potential risk, important identified risk, important potential risk. So again, this is a concept for discussion some other time. Now I will proceed to different case scenarios. Okay. So I want access from you. I think I have around 4 case studies. Okay. So how many of you are aware isotretinoin is a drug which is used in management of cystic acne? Yeah? Yes or no? Yes. Okay. So this drug is it is associated with teratogenic effects. So it should not be consumed by women who are childbearing age and planning to conceive. So how do you make people aware? Okay, this drug has got an inherent risk. It can lead to teratogenic effect in the growing fetus. Okay, so this is a risk which is associated with isotretinoin. As a pharmacovigilance professional, as pharmacy students, as medics, so our responsibility is to develop a risk management plan. We have to bring in requisite guidelines. Okay, so if you see the carton, the box of isotretinoin, it clearly mentions it should not be consumed by pregnant women. Okay. Something else is also very important. All the stakeholders should be involved in decision making. Okay. So a doctor is prescribing. Okay. It is his or her responsibility to inform to the patient that isotretinoin can lead to teratogenic effects. Okay. So all the stakeholders should be involved. The doctor should apprise the patient. Okay. And the pharmacist who is dispensing the medication have to make sure give sufficient instructions to the patient who is consuming it. Okay. So that is how the information should be propagated. A lot of times it happens that patients are not that literate enough, they will not follow. We also need to have adequate warnings on the box. So if you see the one above, this is a pictorial representation. You put it on the box, even if the person is not reading what is written, at least he will see the pictorial representation and tell that okay, it should not be consumed by a pregnant woman. Okay. So communication, we've been discussing about communication so often this morning. So robust communication is very important. Okay. The doctors, the pharmacists, so they should be aware of the side effects of isotretinoin and subsequently communicate to the patients as well. Apart from that, women who are of childbearing age, planning to conceive, or like they've missed a period, so they need to do a during pregnancy test and check whether they're pregnant or not. Okay. Another case study. So we do come across a lot of instances wherein children. So I've just spoken about cough suppressants, not just cough suppressants, any medicine, any syrups. So it is very common that you come across children, toddlers, 2 years, 3 years kids. So they consume these syrups inadvertently, and the parents or the caretakers rush them to the emergency department. So don't you think this is a risk which is associated with the syrups and the liquid preparation? Not just for syrups. We do come across instances where a child would have consumed a lot of tablets. So how are you going to mitigate this particular risk? Yes? Yeah, it's already written there. So you have to apprise the stakeholders that they should be kept at a safe distance. It should not be accessible to the children. As pharmacy graduates, you would have come across instances where we get a new lid, wherein it is only accessible by the adults who know how to read the instructions and open it. Children are unable to open those particular lids. So you need to promulgate such kind of strategy and see to it that these sort of inadvertent drug exposures, overdoses are avoided. Okay. So now I have 2 more case studies. So I will be expecting the answers from the audience. Okay. The third case study. So methotrexate is a drug which is it's an anti-cancer drug used in also in some autoimmune condition. So it is prescribed in rheumatoid arthritis patients. Okay, it is a weekly once dose in an ideal scenario. Okay, we come across patients who end up taking it daily. So as a healthcare professional, how are you going to mitigate this particular risk? Yes. Anyone? Volunteers, please, or otherwise I'll start picking up random people and ask them. Yeah? Feel free, come on. I know you guys are shy, you have that answer in your mind, but yeah, I would love to hear from you. Or maybe I can ask some random people. Yeah? Someone first bench? Yes? Now I know, that postprandial somnolence is a real thing. So let me go back to the first question. Is pharmacovigilance necessary? Yes. Yes. Okay. Thank God we are awake. Okay. So any volunteers? How are we going to mitigate this particular risk? Okay. Let me give the answer and ask you whether it is right or not. So, is the physician responsible to intubate the patient who is consuming the drug? It is a once weekly dose. Yes or no? The pharmacist? Yes. Yes. Is he responsible to apprise the patient? Yes. What else we can do apart from, apprising the patient? What else we can do? Probably we can just dispense only one tablet and ask the patient to come after 1 week and take it. Or maybe instead of having that 10 tablets or 15 tablets or 30 tablets in single, strip, we can have it maybe single tablet strips, right? So that is one possible strategy. Okay. And okay, let us now go to case study 4. So HLA B5701, this particular allele is responsible for hypersensitivity reactions to abacavir. So what is abacavir? Abacavir is an antiretroviral drug, one of the effective drug used in antiretroviral therapy, right? Anti-HIV drug. So patients who have this HLA B5701 allele, they are susceptible to develop severe hypersensitivity reactions, which at times can be fatal as well. Okay. So how are we going to reduce this particular risk? Yes. Come on, guys. So, as a physician, I will not know, okay, who is HLA-B5701 positive or not. As a pharmacist, you may not know it. So how are we going to identify? Yes? Simple guys, anybody who is being put on available, let them get the HLAB 5701 testing done. Otherwise, don't start the medicine, right? Simple, isn't it? Yeah. The guidelines also states that even the US FDA recommendation is a patient who are being started on available, they have to undergo genetic testing for HLAB 5701 positivity. Okay. So let me go back to a couple of slides. Okay. So we have seen. We are proposing a strategy, we are implementing it. So checking that particular strategy, whether it is working or not, we need to evaluate that as well. So let us go to that particular. Okay. So is your risk minimization strategy effective or not? Case study 1, isotretinoin. Okay. So what you can do to check whether that particular strategy is effective or not? So you can do a survey of the healthcare professionals who are involved in prescription and dispensing of isotretinoin. You can ask them whether, they are actually involving the patients and informing them that this can be dangerous. So you can do surveys. So you do some sort of a awareness program. You check the pre-awareness. What was the knowledge of the healthcare professionals? Subsequently, you can do a post-training, post-awareness survey where you can see whether this is being really understood and being conveyed or not. So that is one thing. Apart from that, to measure it objectively. So, like let's say before a pharmaceutical company or the regulatory agency, they started evaluating isotretinoin-induced teratogenic effect. There were let's say maybe 5 cases in 1 lakh deliveries. So we need to check whether this number is going down or not subsequent to introduction of this risk management plans. Do you agree with this? Yes? Okay. So now let us go to the second strategy. Second strategy also similar thing. You're going to check, you're going to conduct the surveys and check whether this particular strategy which you have proposed is really working or not. Whether the number of children with inadvertent drug exposures and overdoses, is their number going down or not? You're going to check that. So if it is going down, yes, it is. Your strategy is actually effective. In real-time scenario, you might also come across a scenario where your aim is to make this sort of an adverse event, this particular risk to zero. But you would see that okay, it is going down, but it is not going effectively to zero. So in that case also you need to evaluate your risk management plan and you need to check, you need to propose some additional thing or not. Okay. So what can be the different risk management, risk minimization activities? This can be upgrading the label. You have the black box warning. You can have some DHCP letters, dear healthcare professional letters, which can be sent out to healthcare professionals. Okay, so we have seen any investigation which needs to be done as part of clinical practice. Yes, HLA 5701 testing for prescription of avegavir. So that is as per recommendation. You can also do some of the tests which are actually not mandated clinically, but just to be on the safer side you can do. So prescription of statins. Some of the patients might come up with muscle pains, myopathy. These are known class effects of these particular drugs. Okay, you can plan for maybe doing creatine phosphokinase, which is a marker for muscle injury. You can do a baseline value and try to repeat it maybe after 1 month or 2 months of prescription of statins. So these can be the various steps. And mind you, this is nothing like a rocket science. These are very basic things, simple strategies. At the end of the day, they make a lot of difference. So I'll keep my session short. This is my last slide, last but not least. So I think at least everybody agrees that preventative pharmacology is something which is very essential, right? So it goes a long way in reduction of side effects. It is not just like you get a side effect, you report it to the pharmacovigilance program of India, or if it is a rare case, you sort of publish it in a journal. So that should not be the aim. Your aim as healthcare professional is to reduce the incidence of adverse effects. Apart from that, the risk minimization strategies, these needs to be rigorously evaluated. They have to be, their effectiveness should be periodically checked. Okay? So that's it. Questions, please.
Hello? Hello, respond. Respond means you receive. Okay. Okay, so I wanted to add a few things about my association with Sikatula sir. We met first time I think in 2016. Okay, so it's been like 7 years journey. So after that I started company Avenida. It has multiple things. One is Avenida Academy. So sir contributed immensely to Avenida Academy. So I was happy but I wanted more. Then I started Avenida practice. Then I sought his help. He helped me there. Then we started something called Avenida Health Services. Then again I approached sir. I started another division. I need some support and guidance. So he was there. Then we started another company, Kairos. Then we approached today, sir, with Kairos we are doing some good work, we need your help. He was there. Then I am indirectly associated with something called Think Roman, where sir is actively involved. So if you meet right people in your life, so they can help you in so many ways, and this is not the end of the list. So then, so at the end of the day, everybody looks for a placement, right? Whatever you learn, that should result in a good job opportunity. Anytime. Okay, I'll give you a very fresh example. So I know one of my students who worked in pharmacovigilance for some time, and she took a break. She wanted to learn yoga. She became a Hatha Yoga teacher. She attended the teacher's training program, and she's a Hatha Yoga teacher now. So she wants to come back to Hyderabad, set her yoga studio, but also parallelly work as a pharmacovigilance professional. So somewhere I heard that there are openings at sir's previous company. So I said, sir, one of my students is looking for a job. Are there any opportunities? He said, there are opportunities, but not for freshers. And luckily, this girl is not a fresher. She had a couple of years of experience. So I said, I know somebody who is looking for a job. Can I share your LinkedIn profile with her? He said, why to share LinkedIn profile? Directly share my contact number. So I am very sure soon sir will do everything possible to make her get a job. So this happened today morning. Okay. So apart from that, so I should thank my classmate Raghavi who connected me to sir. Earlier initially they were part of Regiment Safe. So I used to build sir. Sometimes if I come to Regiment Safe, it felt like my office. Like all the students are almost my students. Okay. And they got an opportunity through sir and like Raghavi. Then Regiment Safe was taken by PPD. And most of them was at least with Raghavi's support, around 20-30 people referred to PPD sir. And then it became Thermo Fisher, now it is R7, even in R7 at least. When they started initially, they wanted like 5 to 6 people. So I referred 5 to 6 people and all 5 to 6 people got selected. So I want to use this opportunity to thank you for everything you have done for us.
So that was very kind of Karthik, but let me put it across on record that the person who is coming for the interview, he or she should be good, he should be knowledgeable. So Karthik has said across very knowledgeable and very intelligent people to us. So yeah, credit to them as well. So one thing from an industry perspective, no doubt you are in your families, B.Pharm and Pharm and some of your medics as well. So one thing what I would suggest is for any opening which we have, we do get around 10 to 15 resume for one single opening. What we found is people are not adequately equipped to handle the interviews. What they study, what they do in the college is different from what is the ground reality. But I think having such programs definitely helps. That will give a sense of reality to the students, what exactly is happening in the industry, and that will keep you better prepared. So I hope no questions from your end. Apart from risk management plans, any other thing you can feel free to ask me from an industry perspective. I'll be happy to oblige. Yeah, I think we're good. So thank you so much. Thank you to the organizers as well.
Thank you, sir. I'm fortunate enough for thanking you for sharing us the immense knowledge about risk management associated with pharmaceutical products. We look forward Now I request you to accept the felicitation. I request co-chairman and chairman sir to join the felicitation. Now I request Dr. Shamsundar sir to accept the felicitation as a token of remembrance. I request Speaker sir and Co-Chairman sir to join the felicitation. I request Dr. T. Ravichandra sir, HOD of Bhardevi College, to accept the felicitation as a token of our gratitude. I request Chairman sir and Speaker sir to join the felicitation.
Now we look forward to moving to the next session on Six Sigma in clinical pharmacy and supply chain. It's the time to welcome and introduce the guests of the session to the audience. I'm profusely elated to take an opportunity to introduce the chairman of the session, Dr. A. Venkateshan sir, Principal of SBS College of Pharmacy. Please come on to the stage. I also feel privileged to welcome Dr. Shankaraya sir, HOD of Chaitanya Institute of Pharmaceutical Sciences, to occupy his distinguished chair. Now I cordially invite Mr. Neeraj Dagar sir, Vice President of Rainbow Children Hospitals, Hyderabad, to manage this institution and eliminating ideas. Please come on to the dais to grace the stage, please. Now I request Dr. Shankaraya sir to introduce the speaker of the session.
Very good afternoon, everyone. So it's an opportunity to introduce our today's speaker, Mr. Neeraj Dagar, Vice President, Commercial Rainbow Children's Hospital. Mr. Neeraj Dagar, Associate Professional with 15 years experience by healthcare industry, specialized in supply chain and data analysis. Sir has finished his graduation from Rajiv Gandhi University, then MBA from the Walkinka Institute, Mumbai. Sir has played a pivotal role in different industries as a professional works in Zydus, Affect, Escort Hospitals, and Kokilaben, Dhirubhai Ambani Hospital, Hinduja Hospital, and Sir has an expertise in the field of the data analysis, Power BI, robotics, and process of automations. So much experience is there in the supply chain and and the data analysis of the hospital management. So now currently working as a vice president of the Rainbow Children's Hospital. Welcome, sir, for this session. So, thank you very much.
Sir, now I request Mr. Neeraj Rabai sir to start the session.
Good afternoon, everyone. Just now we have spoken about risks. A couple of risks have already we have declared. One of the risks which I feel taking a session after lunch. So if you ask me, if you don't have anything, you are empty stomach, you don't have energy to listen. If you are full with food, you don't have motivation to listen. So I need to drag the motivation to listen the topic. I will make sure the session from end to end will be interesting. I will give you a real life scenarios how things go in a hospital. So I call it tug of war. You might have played in your life. So we play daily, day in, day out in hospital. So it's a routine when you start any operation, there will be the kind of pressure, the kind of the operation will have so expect you have entered and finally in the hospital setup as a manager of any operation. It might be a supply chain, it might be a clinical operation, it might be any others. You might have floor coordinated. Everywhere you need to manage it. Lot of communication, lot of stress, lot of egos, lot of differences between the different stakeholders. So whenever you wanted to understand a process, first you need to see the flow, how I have taken a receiving of a material till a complete cycle. One case study, how things will flow in a hospital setup. We might see a pharmacy is the easiest job of a pharmacist. Receiving a material, cutting a strip, dispensing. But it's not as easy as we think. It's not less than doing a surgery. A lot of planning, lot of forecasting comes in picture. So then we have to review where are each year, every time when you review your process, you find some areas of improvement. So we call it a continuous improvement area. We cannot have a benchmarking which will be continuously stand towards a best performance or a best available protocol. Protocol need to keep updated. So here I identify areas where so this is the process start from receiving, main store, purchase, vendor. So in each process you can identify 10 loophole areas or 10 to 15 projects. So I work in a manner where we identify projects or areas of improvement. Then we need to think on which strategy will follow to improve that. So these are the areas I have identified as a project. Now I will take you to a hospital setup. I will give you how the things move in a hospital. You will have a nursing unit. Hope is visible. Nursing unit is there. Then you will have a pharmacy setup. Nurse, doctor. Doctor will give a prescription. A prescription goes for the reconciliation of medication. Step 1. You have first point of thing where the pharmacist will involve. Once reconciliation is done, nurse come in picture. Nurse will have intent, or you can say transcription from intent to a system intent. EMR we all may declare the India maximum hospitals have adopted the EMR, but I say is not a complete take 10, 20, 30%. Beyond that is very difficult to push a doctor for a complete online medication. So transcription is again the area where we have errors. Then pharmacist. So the pharmacist job starts from here. First, nowadays each hospital will have a clinical pharmacy role to play. Now we need to think, demand is huge. So I have worked in a setup where we had 750 patient beds and you have 80 to 90% occupancy and you have one clinical pharmacist. So how you manage this kind of load is next to impossible. So you need to be innovative. You need to be identifying a new technology, how I can increase my role in a hospital and give better outcomes. So appropriateness will be checked by pharmacists. You have multiple things to check at appropriateness level. Then punching of patient intents. So pharmacist assistant is one more key role in your ecosystem, who plays a in and out role whenever you have a call from nurse, critical, urgent. They are the guys who we call it a picker, some hospital, some hospital call it GDA, general duty assistant. They will go, they will take the medication, they will arrange the table. The pharmacist will review against vouchers, they validate, acknowledge that everything is correct. After voucher sign off, the road start off. Third stakeholder, which is the runner. You can say the courier boy. So these guys are the connect between pharmacy and nursing team. So anything which pharmacy acknowledges but has to be delivered, these guys will receive and they will hand over to a nursing team. Their team will again review, check, voucher-wise things and acknowledge I received what material. Post that, the process completes. So this is a normal scenario of the pharmacy operation, how it goes, the flow, just give you understanding in hospitals, what are things which are stakeholders. Now, two things which need immediate attention, what is that in a hospital? If I talk about I take care of commercial and even I involve in the operation part, according to me, first is waste. So waste doesn't mean we are talking about the inventory waste. Waste can be anything. It may be operation resource waste. We are not utilizing a clinical pharmacist as a clinical pharmacist is a waste. We might not able to give a right job to a right person. We are not able to give a right skill to a someone. All, according to me, need to be counted as a waste of a process, waste of a material, waste of any kind of which impacting the organization in a negative way. Then we have a supply and clinical pharmacy operation efficiency challenges. So one is waste, second is efficiency. How we can build the efficiency in the overall process of hospital operations. So the two main quality things which we need to, whenever we review any process, operation, there are two methodologies which is used in management for the quality assurance. One is lean, second is Six Sigma. So we are now understood how operation works. Now at any point we need to keep reviewing what we are doing is correct, is there any scope of improvement, or where we can take it to a next level of outcomes. Lean take care of your waste management. So if we adopt the technology of lean, it will give you a methodology which help you to reduce the waste management in our organization. When we talk Six Sigma, it helps you to improve your processes, improve your efficiency and the outcome, and you can deliver better patient experience. If we say we wanted to achieve both of them, if we combine Lean and Six Sigma, which is Lean Six Sigma, it as an overall methodology, it is used as a strategy to improve waste and process improvement. So now we go a little more focused approach. What is Lean? So you are talking a big talk, which is I need to deep very simple like that. What is Lean? So Lean means better one. So Lean helps you to reduce waste. Where second factor, Six Sigma help you to improve customer support, improve elimination of waste, and improve your efficiency levels and reduce your turnaround times. But what is waste? Still we are not clear what is waste about. So waste is any step or any person which is not adding any value in a process for the outcome of the patient, which is known as a waste. I'll give you an example. In a software where you are dispensing a medication, suppose when we review any process, what is the right way of review? If you want to give an example of pharmacy dispensing, so you need to see each motions involved in a process. It's not a step. I will call it each motion involved in a step. So pharmacy dispensing, you need to see how many steps one person is taking to pull one tablet, how many steps he is taking to deliver the medication, what is the lift waiting time. Till that level you need to monitor and register. Then you know is this step is adding value or not. Sometimes we know it might cause the simpler things. He will say here what sir is talking about. Layout. Layout also leads to some kind of delay. You can say the fatigue in the end users or the staff. If the fast moving drug, you know that each and every patient will have an IV fluid or some kind of tablets. If your layout is not well designed, it's not a unilateral kind of dispensing process, you might end up in adding more stress to your staff and delay in delivery of your services. So we divide waste into 8 different categories. One, transportation waste. So if you feel the way you are transporting inside your building for any material or service, you have a scope of improvement. You are taking a step which is like, I'll give you a small thing. Your F&B delivery timings of food and medicine is on same slots. You might land up in situation your lift waiting time is high. So if you have the kind of deliveries planned in hospital in a best slotted manner, you know my ICU load will be high on this time, my ward will be having the discharge patient on this slot. So that slot need to be mapped with your flow of transportation well in before. So you can achieve the best outcome of the service. Second is inventory, definitely important factor which plays a role. Motion, waiting time of our information. So sometimes we wait for information for discharge. Patient is planned for a discharge, doctor is not aware. Patient is planned for discharge, nursing is not, but information is not passed to a doctor, not passed to your end users. So the experience, your outcome is superb. Patient came out with the superb outcome, no any kind of complaint. The purpose he came is achieved, but still this unhappy at the last day. Then over processing, few things you have to agree with me in the hospital. Just for a policy sake, we do over processing, over documentation, which is not required. And you ask them who told, sir, it is recommended. Where recommended, no one knows. Same documentation will be done by nursing, doctor, pharmacy, quality, and the quality guy will come and ask you 100 questions which is not relevant. Just now we have gone through a JCI application. In JCI application, we spend more than a certificate value in the just suggestions. If it comes to JCI, might ask if we should have this area to be renovated well, whether some incidents can happen, they should be able to get, sir, we have a license, we have file license, everything is there. Why you need to discover something new? So which happens in it, and take the documentation. So now lean, we divide into what strategy do we use. So we understand what is lean. Lean is now how to process further the lean methodology. We use JIT, just in time methodology. Few things we know, no need to have the kind of town hall discussions or deep drive. You know the answer need to be implemented. Just take quick call, inform your superior, do small changes, which will lead to a. So I'll give you a small example. In my JCL audit, someone told what is your ADR tools, how you know the ADR is reported well, how you know the ADRs are captured completely. I call Karthik. Karthik, I need to some kind of database, how to capture the ADRs. If you have a good detailed kind of data, I prepared an algorithm and system. Updated my RPA tool, we use robotic process automation as a tool. So now the life becomes very easy. The morning if someone requests for Melox injection, next 1 hour there is escalation for level 1. If level 1 is not acknowledging, it will go to level 2. So your ADR reporting suddenly has gone multifold. It was not there before, it was under-reported, not reported, and people are not knowing also. So if you use small technology, which is not much costly also, only thing you need to have a commitment to improve, you need to have a thought process to improve, you will get an outcome which is low cost also. So that is 5S. 5S is nothing, just keeping things aligned. The way you know your mother keep your kitchen, rice will be at rice place, sugar will be at sugar place, that is 5S. In simple terminology, you should know which metal should be where. In hospital, if your patient charge sheet should be on the lab drawer, it should be in lab drawer. If your best example is a crush card. If your crush card is not managed well, is a disaster. So you can say the way you define my adrenaline, atropine, my saving will be in which emulsion, where it will be kept, how much quantity it will be kept. Is the best example of 5S. Then Kanban is the technology which gives you an easy access for the information. Like you don't need to have a deep dive in data, what happened. You should have easy dashboards in the flow where they know their KPIs, how they are performing, what was the outcome, how many areas they have reported, how many medication errors have been done. So each critical points need to be displayed in your working area. So the end guy who's working in that area should know which thing is happening and how we are performing. Are we 100 out of 90? Like you guys will have a marks card report every semester or annual basis, how much you have scored. Same way in a hospital operation center, they should know their score, how they are performing. That is Kanban thing. Then what methodology we use is a DMAT for the Six Sigma. I not go much deep, I think we are running out of time. So we define the problem. So DMAT is the theory which is used wherever we are not knowing the solution of the problem. Where JIT and the other people, we know the answer but only think how to plan it. There DMAT is used to identify a solution. Solution is not identified, problem is identified. So we identify, define problem, measure problem, analyze problem, then look for a solution to improve, and then set up controls in a system to ensure things are going well. So what benefit comes out of Six Sigma and Lean? You will have an increased profit. You are simplifying the process, reduce the errors. So your errors will be reduced. Value for the customer you provide is the ultimate goal of us and employee development. We can develop our employees. I just skip these things. Just the parameter I know how to plan it. The clinic pharmacist, drug reconciliation, drug interaction. So we need to have interviews of each stakeholder before approaching to a DMAT methodology. So interviews you need to just, this is the way we have done the interview, we have done the review of layout, and we came out of what are improvements are there out of Six Sigma. So each point the matters key, which is things are going on as per the expectation. So I just skip this. So this is a small example. The person is standing and doing the pharmacy dispensing part. Same guy, we try to convert the guy is still comfortable checking the same medication, it adds value. The person is more motivated for the outcomes and they do better job. Then SOP need to be displayed in minimum quantum each area of action point. So each action point SOP should be displayed, whether it's receiving, dispensing, your appropriateness check table, something you have like a legal pharmacy table, all information on how it will pass to the single steps should be displayed. This is the way we do check, like each step will be trying with the staff, understand the what need to be done, how it will be done. And out of this 3 or 4 strategies, what to choose, we have a scale kind of thing, where we use BDC, where we use DMA, where we use CanGen. So depends on that we plan for each problem, what solution need to be planned. Thank you.
Thank you, sir. Thank you for the enlightening speech, which made us filled with vast knowledge. And we are truly grateful for sharing your valuable insights.
Okay, so you want to hear my journey with Neeraj? Song what nice. Okay, so how I met is through one of my students again. Oh, how many medicine students are here? No one. How many families raise both hands? Legs also you want to raise? And he chairs in front of you. Okay, so one of my students, he finally and then MBA and joined Rainbow. And then he introduced me to like Neeraj. So I went and waited for 2 hours to meet him. Why I am telling that today is it is not easy to get access to such people. So I want you to understand how difficult it is for a person like him to make time and come today. And yesterday, these days, sleeping maybe 1 a.m., waking up 5 a.m. for last 2-3 months. Okay? But in spite of that, he made time and effort to come here. So I want all of you to like acknowledge and give a response. So going back to the story, I met him. Then I said, why don't we introduce a clinical pharmacist in your group of hospitals? So did you ever try that? To face a lot of resistance. So even if it is your own affiliated hospital, to get access to patient's case sheet and do what we are looking to do, it is very difficult. But I was complete stranger. The only point of contact was my student who joined very recently. Then I went there, I requested him. But the kind of relation he has with is good. He directly speaks to CEO and even the founder, he has access to that too. So he said I will make it happen, and he gave us a branch where chances of this pilot to get successful are there. So we did a 3-month pilot, it went well, and after that so many things like progressed, and now they have hired how many CPs in their network? So more than 10 clinical pharmacist opportunities that led to creation. Okay. So that is to make things happen, it is not easy. So next, coming to that rigor, to thanks for acknowledging that. So why I am telling this is to tell you what the things which you learn will definitely be useful at some point or the other. So this rigor, to let me share this example. So when I was finally 5th year, we do a project, right? So I was given a project which I never liked to do, but I still did it. Okay, so it is like arranged marriage. I wanted to marry somebody, they said. So by the way, I am not married. So okay. But my friends who were doing other projects, it was more interesting for me. So I learned from them. So from this, what message I am trying to tell you is, don't just learn from project which you are doing. Learn from all the other projects happening parallelly. And one of those was about areas where they use this rigor to technique. So I learned that concept, but I never got a chance to implement. But all of a sudden, maybe a few months back, like he called me and said, we want to improve the process of reporting or understanding areas, what can we do? Some reason my brain got well, I went into flashback 2013. 2013 is how many years back? So a point which I learned 10 years back, I had an opportunity to implement after 10 years. But it did not go waste. Do you understand? So in that way I can give you 1,000 examples, the things which I learned in second year, which I felt why am I learning all of these things? But I got a chance in 6th year to implement. Sometimes in 2023 I got a chance to implement. Okay, so So Neeraj has launched there are few good people who are open to admit their mistakes and they are good so that they share their experience so others don't repeat that mistake again. So he has learned a lot in supply chain. Okay, sir, let me ask you a question. How many of you would love to have somebody like him, who thinks like him, who works like him, having a family degree? Did you understand the question? So ilanti person family chesina vallu unte happy anu gattiga respond cheyandi. So Neeraj is soon going to become family, so right now I'll appreciate you. So yes, and it is not too late to do anything. So though he has done B.Pharm, MBA, accomplished, vice president is not a small position, right? But he still wanted to do more. He enrolled for a family program and he passed family first year with 85% distinction. And he will soon become a family graduate, so my interest is I can call him part of family very soon. So all the best and congrats. So you can talk to him about your launch.
So my last 15 or 20 years of journey in a hospital, I try to understand that I see many mistakes I have done. Many things have been taught by my seniors, which I was not taking time or repeated errors. So I don't want my next generation to do same thing. So last my journey with Fortis Escorts, Hinduja, IHH and Apollo. So this 15-20 years have given me a good learning and what is right, at least I know, and what is wrong I know. So I try to conclude in one book where recently I published this book where I try to give you each step, each which is not theoretical, practical things to implement in a hospital. I added a technology bit, how RPA can be used in improving your area of operations. That's it. Maybe next week it will be available on the Flipkart, Amazon and many of the bookstores. Thank you.
Thank you, sir. We are privileged to have you with us today.
Okay, so one last thing. So first batch of family, the regular family came out in which year? It started in 2008, first batch came out in 2014. So nobody knew what is family, what these people are supposed to do. So at that point of time, Neeraj was working in Hinduja Hospital and some family graduate, I don't know his name. So he graduated and went there, he was instrumental in that family graduate getting a job as a clinical pharmacist in Hinduja Hospital. So I should proudly say that first clinical pharmacist opportunity was facilitated by him. So another.
So I'll just tell you in 2 lines of story. This guy came to me in my cabin and he's feeling very sorry about he have done founding. Actually, I was also not knowing what is founding at that moment because that's first guy standing in front of me. I asked, is B.Pharm? Now everyone knows, thanks to the kind of program we are doing. Now, so I asked him, yeah, I could not onboard you. I have high regard, someone has done 5 Pharm day, I have a high regard. I'm sorry, I could not able to hire you. You have deserve much more thing about the way you are coming to the hospital. Sir, I am feeling B.Pharm, I had some job, but Pharm day I am not getting any job because no one is knowing in the market. You give me an opportunity, give me some time, moment you have something, you upgrade me. So, good decision I have taken, I hired him as a pharmacist. I have taken 2 months of time to upgrade my superiors or CEOs. This is one thing we should appraise him. And he told, we should not share a salary and all. Because 20,000 is good for me to start something. In 2014 I am talking. I told no. I have given 35 to 47 that movement. I told you should have a respect in the hospital. And this guy now is heading a Reliance Hiranmari Hospital as a head of pharmacology.
Now it's time for presentation. I request speaker of the session, Mr.
Come back. Yes, bro. Back. Back.
join the felicitation. Now I request Chairman of the session, Dr. A. Venkatesham sir, to accept the felicitation. Now I request Dr. Shankaraya sir to accept the felicitation.
कौन दूध का साई
Good afternoon everyone, myself Priya from Final Team. Good afternoon everyone, myself Aisha from Family First Year. Once again, welcome to the TPCP International Clinical Pharmacy Conference 2023. It's my great honor and privilege to stand before you today as we gather here for this remarkable event. We are truly fortunate to have the exceptional personalities among us.
Hello everyone, now get ready for an immersive and practical session on clinical pharmacy. Today we have remarkable individuals who will guide us through this hands-on training. First up, please put your hands together for Chairman of the session, Dr. S. Bala Mohammed, HOD of Pharmacy, MLR Institute of Pharmacy, Hyderabad, who will provide us with valuable insights and set the tone for this interactive session. Let's give him a big round of applause to come onto the stage.
Next, we have our co-chairman having great knowledge and experience in a profession who will share her skillfulness and help us understand the practical aspects of the clinical pharmacy. Let's welcome co-chairman of this session, Dr. G. Hemalatam, HOD Department of Pharmaceutical Analysis, Pathfinder Institute of Pharmacy Education and Research, Warangal. Let's give a big round of applause. And finally, we are fortunate to welcome experts of the training session, Dr. Likita Kadituri, Clinical Pharmacologist, Care Hospitals, Hyderabad, Dr. P.D. Gitanjali, Clinical Pharmacist, Asset Rank Hospitals, who will take us through various aspects of the clinical pharmacy, providing us with valuable knowledge and skills. Please join me in giving a huge round of applause for incredible trainees to join the stage.
Then I request our co-chairman of the session, Dr. G. Hemalata, to introduce trainers of the session.
I'm going to introduce Dr. Likita Kaditur. So Dr. Likita Kaditur is a prominent clinical pharmacist at Care Hospitals, Hyderabad. Dr. Likita served as a joint secretary at the Indian Pharmaceutical Association Students Forum, representing the Andhra Pradesh in the National Council from the period 2018 to 2020. And she gained national recognition when she became the youngest speaker at the 21st Indian Pharmaceutical Congress in 2019, which is held at Chennai. Her presentation topic on opportunities for women in pharmacy, organized by the IPC Council, received widespread acclaim. And she has moderated and spoken at numerous conferences organized by the IPA itself, sharing her expertise and insights. And Dr. Nikita is an alumna of Indian University, Vizag, where she successfully completed her PhD. She combines her remarkable public speaking skills with a deep passion for the research and evidence-based medicine. Her professional journey led her to become a clinical pharmacist, where she has gained invaluable experience, particularly in the management of medications, is a crucial area where her role plays a important in the patient care. With this brief introduction, I welcome Dr. Nikita to take her session.
Now I request the expert to start the session.
Thank you so much, ma'am, for the lovely introduction. Okay, so let's start the session and end it as soon as possible, because I know you all are very much saturated. But to keep it more engaging, I would like to plan a small activity with you all. So are you all ready? Yes. Okay, Dada. So we'll have a small game, which is just a minute. But since we are out of time, we will have a game with seconds, okay? I'll show you one picture and you have to talk about it at least for 10 seconds or 15 seconds, a duration of the Instagram reel, okay? And whoever will speak exactly to my point of view will get a rose flower from my side, okay? So can we have the first time? Where is the remote? So, what do you see in this slide? Yeah, water. So how is it? Messy. Okay. So, who is ready to speak about it at least for 15 seconds? Anyone? Western wardrobe. You can relate it to anything, to your life or to your lifestyle or anything. Everything has a philosophy. Anyone? He took the courage to speak. Please give him a round of applause. Don't worry. This is not an interview. I just want you all to keep engaged, so I want you all to speak. Our wardrobe చూడగానే నీకు ఏమనిపించిందో అది చెప్తాను. Hostel. Okay. You have a very nice taste. Anyone else? You? Yes. We'll go with him first, okay?
మన లైఫ్ని ఇట్లా వాటర్ లాగా మెస్సీగా చూస్తే మనం లేజీగా ఉన్న డేస్ ఇట్లానే అంత మెస్సీగా ఉంటుంది. ఒకవేళ మన డైలీ లైఫ్ని ఈచ్ పార్ట్ ఆఫ్ లైఫ్ని మనకి నచ్చినట్టు లేజీగా కాకుండా ఏదో ఒక వర్క్ మనం నేర్చుకునే విధంగా లెర్నింగ్ స్కిల్స్ ఉంటే ఇట్ విల్ బి లుక్ గుడ్.
Actually, I'm thinking about my graduation. My graduation is like this messy, where I don't know after my graduation what I become. I would do a medical pharmacist or a industry in some other foreign countries. That is my present now. After completing my graduation, I might be knowing whatever it comes, I'll go to it. I have that message after seeing that.
So, how do you think if you like organize it in your thoughts? First, next time this or ఇప్పుడు వార్డ్రోబ్లో మనం మేనేజ్ చేసుకుంటాం కదంటే ఎన్ని వేసుకునే బట్టలు ఒకటి
It comes in mind when we complete all the things. And particularly we have some day I don't want to bother about those things. When I will bother when it comes into my mind. Something like after completing my graduation, I'll think about money. I need money. I need to go somewhere and I need to earn and I need to come to my family. So in that time, I'll set all those things and I'll come to my position.
Nice.
I think the ambience which we keep our surroundings should be neat and clean because it affects our mind. I think the picture shows like depression. Sometimes if we feel like pessimism, it affects our mind. If we be neat and keeping our surroundings clean and neat in an arranged, organized manner, so we can change our mind to neat and we can meet the other persons in a manner which we keep our clothes like an organized manner.
That is absolutely true. Keeping your things neat and organized is therapy. Is a therapy. It was messy, just like my wardrobe also. But if we arrange it in proper way and if we organize the day with daily activities like what we have to do and how we have to organize, then everything becomes easy and good. Yeah. I loved all your answers, but her answer is more relatable what I wanted to portray. So you get all of you get roses, but the physical one is I'm giving to her. Okay. Okay, so what do you see in this picture? What do you see in this picture?
Ingredients, there are different colors and then like sweet, hot, salt, అలానే మన లైఫ్ కూడా అలానే ప్రతి ఒక్క సిచ్యువేషన్ ఉంటుంది. కొన్ని స్వీట్ కొన్ని బాధలు అలా ఉంటాయి. ప్రతి ఒక్కటి తట్టుకొని పోవాలి. లైక్ ఐ థింక్
ఇంకా anyone else?
I feel like it's about to cook something, so we need to know what we are cooking and we need to plan everything.
Okay. Anyone else?
So life is what we make out of it. Every life is in our hands. So whatever the situation we want, we have to it is our choice and it is our decision making. So depending upon our situations and our things, we have to add the flavors. So that is why the good and better present. So it is our own life. We have to write and we have to add ingredients according to our wish.
Nice. So that's it. This time you want to answer or you're going to stick the mic?
Here we can see different types of food items with a different nutrition value. Each has their own uniqueness and each has 1 unit of proteins or nutrients available. This is 1 point of nutrition value. In the second case, if you think, our life is mixture of different patterns of life, like mixture of good things and sadness, happiness, sorrow. It's a mixture of life is composed of different. Like Ugadi is mixture of different things.
feedback. I think the rose goes to you. You finally complete that. So why I wanted to show these pictures is that I wanted to relate them to reconciliation. But before that, I wanted you all to, open up and be more attentive. So, like you see in the first picture, a messed up wardrobe. Okay. So reconciliation, medication reconciliation, I think you must have heard about it. It is nothing but preparing a compatible list of medications. Okay. So when a patient gets admitted in the hospital, he may get admitted in the ER or a direct admission case, right? So will he stay in the ER? Based on his condition, he may be shifted to OT, right? Or to ICUs, or to wards. So there is a journey of the patient, okay? And there is a transition point. He is being shifted from one point to another point. So all this is a journey. And every ward or a particular area has particular treatment. In ER, we give stat medications, right? In ICUs, we give high doses. And then when we shift to ward, we convert them into oral forms, right? So where are we organizing all these medications? It is not messed up. So when you finally look into the case sheet, if you have gone to MRIs and all, you can see ER treatment will be in one sheet, ICU treatment will be in one sheet. So this is not messed up, just like that wardrobe, right? So reconciliation is nothing but we will be organizing all these medications and checking the compatibility, and we will put that in one single physical form. So this ensures patient safety, right? And this is a picture of a recipe. We add, so if we want to prepare any food item or anything, we add salt or pepper or anything according to the compatibility, right? So we every ingredient requires different amounts of spices and all, right? So why is it important to check the compatibility? To some items, less amount of salt is required. To some, in tea, can you add salt? No, sugar. Okay, so just like a recipe, reconciliation is also checking the compatibility, and we adjust the doses also accordingly for the treatment of the patient. So just like a good recipe brings out a good dish, good reconciliation can ensure safe patient, okay, safe treatment. So that is why I posted this picture. Am I clear to you all? So I'll just quickly talk about few things. What is reconciliation? Why is it required? And what are the steps involved? I told you already, it is preparing a compatible list of medications, and like I told you, we are assembling all the list of medications in a single physical form, right? ER to ICUs or GOT, again ICU to ward to discharge. Okay, so all this list of medications will be present in one single form, and then monitoring and preventing of medication errors. Obviously, we are the ones to be checking the rational drug usage, right? We have to ensure. You know rational drug usage? What are the 6 R's? Everyone. So no one knows about rational drug usage. Very bad. How many of you are from Poundy? Raise your hands. Now tell me about rational drug usage. Okay. So we will be monitoring and preventing medication errors. So Dr. Geetanjali will be talking about medication errors duty. And the important part, reconciliation is an important part in management of medication chapter. Okay, and so every NABH accredited hospital must have medication reconciliation program, which should be done by a clinical pharmacist. Okay, and like I told you, since we are monitoring the medication errors, it plays an important role in improving the standards of treatment by ensuring patient safety. Once medication errors are prevented, patient safety is ensured, so it decreases the length of stay in the hospital of the patient, right? So these are the steps in medication reconciliation. First, we will be developing a list of current medications. So not only the medications in the hospital, even if the patient has any existing comorbidities like hypertension or diabetes or be it anything, so he will be having some past medication, right? So that will be also recorded, because in most of the hospitals, the patient may not inform, or the doctor or the respected healthcare provider may fail to take the information of the past medication or the medical history. But when Okay? And then we develop a list of medications to be prescribed according to the doses and existing health conditions of the patient. And then we compare the medications. And then we check the compatibility. Okay? And then we communicate the new list. So this is the simple 5 steps in medication reconciliation. So I'll just give you 2 cute examples, case studies. So 73-year-old female patient with a known case of hypertension and rheumatoid arthritis came to ER with complaints of dysphagia, difficulty in eating, swallowing and burning sensation over the throat, hemoptysis, oral ulcerations and fever. On examination, her blood pressure, platelets, WBC were like that and lab findings were. So she was diagnosed as mucokidatitis ulcerating oral cavity with marked leukopenia and thrombocytopenia. So when she was taking this treatment for rheumatoid arthritis, okay, she was prescribed with Folitrax. Folitrax is nothing but methotrexate. Okay, how do you prescribe methotrexate? What is the dosing frequency? Any idea? Weekly once, right? So what happened here is she was not counseled properly and she was taking that daily once. So she had all these complaints. So with reconciliation, we found out that she was taking the medication in a wrong way. So I can tell you that reconciliation helps in diagnosis also. Okay. How were we able to diagnose? Since we recorded the past medication history, we were immediately able to know that she was taking Folitrax. She missed, like, she came in the last stage actually. If she came 1 week later or else, we might have missed her. There was also a death case reported also. So we need to have a proper idea about these dosing frequencies and so when practicing reconciliation, we'll have get a proper grip on all these. And this is another simple case. A 66-year-old female has a known history of hypertension and diabetes. Her BP was 160/99 and GRB is 270. After reconciliation, it was found that her past medical history and medication were not recorded. Okay, so she was a known case of hypertension and diabetes, but this was not recorded. That is the reason why her BP and GRBS levels increased gradually. So with the help of reconciliation, we were able to record it. We informed the healthcare providers, and then it was made very strict that past medication history must be taken in the ER itself, so that we can prevent such errors. So this is how reconciliation plays a major role. Any doubts? Nothing. So I would like to hand over the mic to Dr. Geetanjali. Thank you for your attention.
Thank you, ma'am, for your astonishing session.
Dr. Geetanjali ma'am, post-baccalaureate, is heading Clinical Pharmacy Department and Ethics Coordinator at Esther Prime Hospital, a unit of Esther DM Healthcare, one of the leading healthcare sector worldwide. She excelled her medication therapy management, collaborative healthcare and patient education. She holds a degree of pharmacy and expanded her knowledge frontier by pursuing MBA in healthcare management.
Yeah, hopefully everyone are attentive, right? Sleepy? No? How is the biryani? How is the biryani, guys? Nice? I can't hear you. Nice? How is the chicken? Great? Now, as Dr. Vikita already stated regarding the medication reconciliation, right? Now, everyone has heard regarding MOM. What is MOM? Management of medications is MOM. So, all the pharmacy students, you people are considered as masters and champions of MOM. Understand? Champions of MOM. So, when it comes to champions of MOM means, you are excelled in medication management. So we are considered as champions. So I'll not bore you all with all the introductions and all management of medication. These are the roles of a clinical pharmacist in a hospital setup. What? Medication reconciliation, prescription audit, patient drug monitoring, ADR monitoring, drug interactions, management of high-risk medications, LASA, and also storage of the medications, medication error monitoring. So we will mainly focus on medication error monitoring today. Okay? And NTPS compliances, drug recall, patient counseling. So there is a committee in the hospital, that is Pharmacy and Therapeutics Committee. Okay? Who all are part of Pharmacy and Therapeutic Committee? Any one of you? Any one of you knows? You are looking back there. So let's start. Pharmacy and Therapeutic Committee is a backbone for a hospital, wherein all the errors, maybe prescribing, transcribing, any errors are discussed. It is a tri-monthly program where we discuss along with nursing superintendents, physicians, other operational and also clinical pharmacists being the conveyor of the Pharmacy Therapeutic Committee. Understood? So agenda. What is the agenda of the meeting? Review of previous meeting. For any meeting there will be a previous meeting points where you need to meet up the criteria, right? Review of quality indicators. These are our quality indicators. Next, review of stockouts. To discuss on adverse drug reactions. To discuss on prescription auditing and statutory compliances. Discussion on drug formulary. What is a drug formulary? Any one of you? What is a drug formulary? Telida meeku? Cheppandi? Any one of you? ఇప్పుడు మనందరికీ ఒకప్పుడు we have a dictionary కదా, dictionary. Phone కి కూడా we used to have these many numbers అని we used to have. At the same time, every hospital has a drug formulary, curated drug formulary. Either it may be IP or OP. Right? Inpatient drug formulary, outpatient drug formulary. So these two play a vital role. Okay? Any addition of new drugs, these all will be discussed in PTC committee meeting. Now, let's go for medication reconciliation. What is medication reconciliation? Reconciliation and anything? Anyone? Reconciliation is nothing but comparison of two documents or three, curating it to one to avoid discrepancies. What is discrepancies? To avoid errors. Many errors. You know, omission errors. These all need to be avoided. In the definition also, let us go with real-time experiences as a clinical pharmacist. Okay? When a case comes to ER, as Dr. Lekita already said, ER physician will do first medication reconciliation, that is past medication history with certain comorbid conditions. Like what? Hypertension and diabetes. Most easiest thing we can say is hypertension and diabetes. He is not telling me sartan and metformin. Patient came to ER. The patient attendant doesn't know what medicines has to be taken. So what will happen? Next, the patient is shifted to ward, right? Or an ICU. There are transition points where ward from ward to ICU also they will shift. So these curated A, ER, B in the ward, from ward to ICU 3, and at the time of discharge 4. 4 checkpoints, right? 4 transitional points has to be noted. Then, completely if you don't give a medication reconciliation to a patient, he might end up in different errors. So medication reconciliation is a very important part in the patient care. Role. This is the example of a medication reconciliation form. Okay? Let us come to prescription auditing. Any one of you who knows 3 lists of prescription audits? Anyone? What is prescription auditing? What is prescription auditing? No? Let me only say, there are 3 types of auditing. Okay? Before the prescription, after the prescription, during the prescription and after the prescription. Firstly, there are 2 types of prescription auditing. That is IP prescription auditing and OP prescription auditing. What is IP prescription auditing? Inpatient prescription auditing and OP. We have 2 types again. Manual prescription auditing and as well as EMR prescription auditing. What is EMR? Electronic medical record auditing. Now, medication errors. This is the chapter we need to look into most because our lives are run around medication errors. What are 5 important types of medication errors which we actually look into? Prescribing errors, transcription errors, dispensing errors, administration errors, error of wrong drug selection, error of time, wrong time errors, omission errors, monitoring errors, compliance errors, wrong preparation errors. What do you mean by wrong preparation errors? For cancer patients, chemotherapeutic drugs will be prepared. The formulation will be prepared, right? Those are wrong preparation errors. We categorize into 9 forms. Category A, B, C, D, E, F, G, H. Okay? Now, as we already know, blue is no error. That means circumstances have been created that patient might get into an error, but we have missed it. That means no error. Now, error, but no harm. Potentiality is there where error has been occurred, but it didn't reach patient. Okay, that is no harm. Next we have yellow, that is error and harm. Error has been done, reached the patient, and also there must be some monitoring or some additional treatment or medicational management need to be provided by the hospital to the patient. And now error and death, right? Error has occurred, medication management has been given to the patient, but the sentinel event, the death has occurred. That is the category, 9 categories. Now, role of clinical pharmacologist or clinical pharmacist. Error identification. What type of error it is? Reported to the whom do you report? In which? First, who will collect the errors? Clinical pharmacist will go on day-to-day rounds and collect the errors. Next, RCA and CAPA. What is RCA and CAPA? Any one of you? No? RCA is root cause analysis. What is the root cause for the medication error to happen? Okay? CAPA is corrective and preventive action. Corrective action and preventive action to further reduce the medication errors. Okay? Now, RCA. RCA is always done by 5Y analysis. Keep in mind 5Y analysis. How, where, when, why, 5Y analysis. If you start a problem, not only medication, regarding any problem, do your 5Y analysis, you will get good answer. Okay? CAPA. Most of the time, lacking of training and lack of communication will be the reason of medication errors. Now, I will give you certain examples in medication errors. Okay? Prescription errors. Illegible prescription. What is illegible prescription? Doctor writes a prescription in a illegible way. Okay? Will pharmacist able to understand it? No. So to avoid that, what we have to do, capitalizing the prescriptions is important. All the letters to be in capital letters. And the drug has to be mentioned clearly to avoid prescribing errors. So let me talk about dispensing errors. Okay? A 12-year-old boy with seizures. Okay, what is generalized tonic-clonic seizures? Rimodin is a drug which was prescribed by the doctor. Because of his lack of writing skills, which drug has been given is prednisolone, which is a steroid. Right? What would patient end up in? Anyone? Anyone? Steroidal therapy along with his seizure therapy. What would have happened to the patient? What is the clinical scenario that patient would have suffered with? Along with steroid therapy, seizures, right? 3 months we have taken prednisone. He'll end up in diabetic ketoacidosis, thereby death. Right? That is sentinel again. Now when it comes to administration errors. A nurse was working, she was so busy, she had time constraint, she was hurrying from here to her there. Usually nurses move very fast for the, days. If there is a time where 8 o'clock this patient, that patient also 8 o'clock. So they have been hurry. So there is a patient who got intubated. Okay, intubated patient. Okay, she didn't read. She didn't read what? Do not crush on the medication thing. And she crushed the medicines and put it through nasogastric tube. Okay? What would have happened to the patient? What would have happened? Calcium channel blocker. Crush chesi nasogastric tube lo iste emantaru? Heart rate slow ayi cardiac arrest vastadi. Okay? The administration error. Dispensing error. Lookalike sound-alike drugs have to be kept separate so that it will not cause dispensing errors. For a classic example would be saline and mannitol. In case of saline, NS they have given mannitol. Patient will end up in any one of you. Seizures. Okay? This is a medication error chart or form where you can fill. This is corrective. Now there is a corrective action and preventive action to be done. Who is causing what kind of error? ADRs. What do you mean by ADR and ADE? Any one of you? I will find first name or else if you want to say. So as a time constraint. So this is ADR monitoring. We have to report an ADR to PVPI. Okay, most of the ADRs are caused by the antibiotics. Okay, there is an incision, transdermal incision. Okay, the 0.5 ml of an antibiotic, let's say doxycycline, has given to the patient. There is a checkpoint where nurses has to monitor 15 minutes after giving intradermal injection. Now after 15 minutes, rashes has been seen. So you have to submit to PVPI. Okay, ADRs. NDPS, narcotics, drug and psychotropic agents. What are narcotics? Fentanyls, morphine, etc. Cytotoxic are midazolam, etc. So there is a curated process of narcotics. There will be a triplicate prescription, which is 3 prescriptions, which is yellow, white and pink. Okay? Yellow has to be kept in, white has to be kept in pharmacy, pink has to be kept in clear sheet, and yellow has to be kept in the booklet itself. Drug recall. You can see how the color changed in amoxicillin. Right? What is drug recall? If a drug has not been kept under ideal temperature, there is a chance of drug recall. Right? The drug is incompatible and further will not be able to administer to the patient. If we administer the incompatible drug, it may lead to serious adverse drug reactions. Now this is the format where we have to submit to vendors from where we have bought the drugs. Right? If you see, recall has to be done within 24 hours by checking multiple vials of the same medication. Antimicrobial stewardship also plays a major role. Antimicrobial stewardship team include infectious disease physician, clinical pharmacist, clinical microbiologist, information system specialist, infection control professional, nursing superintendent, epidemiologist and leadership support of an organization. Involvement of clinical pharmacists in NABH, that is MOM chapter. So all the above points are included in this. Okay? Have a look. Thank you.
Am I on? So why we are focusing mostly on medication errors is that because it is the 3rd leading cause of death in the world. 3rd leading cause of death, medication errors. Just imagine a patient or a person is coming to hospital because he is ill and he is dying due to medication errors, and that reason is standing in 3rd position in the whole world. So that is the reason why we have all these programs to control those medication errors. And let me tell you proudly, clinical pharmacist is the only person who can take total charge on controlling these medication errors. So I want you all to focus on that. Okay? So go through this clinical pharmacy chapter or anything, and this is the only area where you can exactly implement what you have studied all these 6 years. Other all fields you have to learn all the extra things, but this is the only thing, whatever you studied in the book will be reflecting in your work. Thank you.
Now I request the chairman of the session, Dr. S. Balamurali Mohammed, to express his thoughts.
So, good afternoon, students. So, have some energy. Just 2 more minutes. So, first, I want to tell that your college, that is your principal sir, Venkateshwar sir, and your college management and principal management has taken a great decision or a great initiative by starting this clinical pharmacy department and planning to include PharmD students for the next level in all the clinical pharmacy services which are going to be in your hospital. Why? Because PharmD plays a very important role in completing of giving the patient care, the complete patient care to the patient, along with the other healthcare professionals, that is physicians, nurses, a pharmacist, particularly a clinical pharmacist is also very important, and he or she is also a part of healthcare team. That's why we are so important. Just now you have seen Dr. Nikita and Dr. Geetanjali, they have given some basic activities what a family student or the family person has to do in the hospital setting. By doing all these things, along with the physicians and nurses, we can give a great patient care. So in our college, so I am from Yamnagar College of Pharmacy. We are associated with Arundhati Institute of Medical Sciences and Hospital. Previously, we were having it tied up with ESL Hospital. From almost last 7 to 8 years, we are doing many clinical pharmacy activities. I am involving all the PharmD students, starting from second year PharmD to 6th year PharmD. We are involving all the PharmD students in many clinical pharmacy activities. And from last 1 year, as we moved into our own management hospital, we got a great support from management side also. So now you are also having the same kind of scenario in your setup. You are going to get a great support from your management and from your college, from your principals, from your faculty. So I hope that you utilize this opportunity. And of course, you are also having a great backup by Karthik sir, Dr. Karthik. So I hope you will use this opportunity. You will try to learn many things by attending all the practical sessions, by doing all these clinical pharmacy activities. And I hope you will give better care to the patient. Right? So with this, I will conclude. And again, once again, thanks very much. Thank you very much to Dr. Likita and Dr. Geetanjali for giving us the insights about the PharmD activities.
Okay, so thanks, Muni. He's from, again, first class PharmD, so Varun sir knows very well. So when this program was introduced in 2008, how many colleges had a permission to start this program? So Geetanjali, you are asking question for every slide. Nobody opened your mouth. Answer no. Or tell me your lucky number. 8, 16. So it is somewhere average of 8 and 16. So very few colleges had started the program. So in my journey, I have met so many people. Most of them are juniors. They joined 2009, 10, 11, 12, 13, 14, 15, 16, until 2022. Like very rarely I get in touch with somebody who joined PharmD along with me. So he is one such person. And we contacted very recently, just maybe a week back. Then when I talked to him, I was impressed with the work they were doing at this hospital. So many people think once they finish 4th year, they call me and say, sir, 4th year is over, PharmD is over, tell me what should I do? Do you have part-time jobs? They ask me. But in my understanding, PharmD starts at the end of 4th year, it does not end at the end of 4th year. And I heard so many institutions, like internship is not happening properly, and they are complaining with other institutes saying they are not doing internship, why should we do internship? So rarely I came across this person who said he makes it mandatory to do full internship. If they fail to do it, they extend. And it is not just for the sake of doing it, but implementing all those activities. So in the last moment, when I got to know about him, I requested sir, but they did not complain, saying he made everything ready, why should we make these changes and invite? So in fact, if you see all this material, so his photo was not very real. But even in the last moment, maybe 1 or 2 days before, luckily just before giving a print, I asked them to make that change, and literally in every printing material they made that change. Do you understand what I'm trying to say? So that is the kind of like attitude and approach you should have. So definitely we will involve you also, learn from your experiences and try to implement things here. Okay, so how was the conference? Respond loudly. So did you like? ఎందుకు సీక్రెట్ చెప్పినట్టు చెప్తున్నాను? Okay, shout with top of your voice very loudly and clearly. Did you like and learn something from morning to today? So do you want to go out of this hall and forget same service? Amma, thanks, no sir. అలవాట్లో పొరపాట్లో ఇస్తారని ఇంత కష్టపడ్డదని ఫైనల్గా బెనిఫిట్ లేదని తెలిసేది. అండ్ మార్నింగ్ నేను ఇనాగ్రేషన్ అప్పుడు చెప్తున్నట్టు సో అంత ఈజీ కాదు ఒక న్యూ ప్రోగ్రామ్ని నెక్స్ట్ లెవెల్కి తీసుకెళ్ళాలంటే మల్టిపుల్ థింగ్స్ ఆర్ ఇన్వాల్వ్. ఫస్ట్ ఈస్ ద హాస్పిటల్ సపోర్ట్, దట్ ఈస్ దేర్. సెకండ్ ఈస్ కాలేజ్ విజన్, దట్ ఈస్ దేర్. థర్డ్ ఈస్ outside support. If faculty will do certain extent, then there is outside support. Outside support is there. Then what else will complete this group? Like students involvement. పంతులు రెడీగా ఉన్నాయి, అన్ని రెడీగా ఉన్నాయి కానీ సో అవన్నీ ఉన్నాయి. ఇక్కడ we should execute them, okay, and we will do it in a step-wise manner, and we are not expecting results in like 1 week, 2 weeks. So we are giving ourselves 2-3 years of solid time, and we will start and do a good job. So finally, our vision is to make it a center of excellence in clinical pharmacy practice, where other people will see this as a model and try to replicate. So are you ready for that? Tell loudly, respond loudly. So somebody record whatever they said, yes sir, and show them every day. Okay. So sir, with this I think we can conclude that. So I have met so many people today, you might have seen. But if I have to pick up few people in that network who inspire me, it should be principal sir. So very, very big round of applause for him. So it is not easy. So much of an effort and many changes. Sir, so thankful to you sir, and extending that support. Of course, the management director sir, Varun sir. Here I have strength is Sir also has the Denmark pharmacy practice background. So here the chances of this being successful are more. Okay, because Sir knows that program. He was part of one of the world's or India's best institute, which has started clinical pharmacy. So now Sir is also involved. So we want to get all of these people together, achieve success here, and replicate it every other college. Okay, so I think with this we will conclude, and if you have questions, we'll be here. You can come and ask us, and photos we can take. If you want to take photo with all of us, you can come here and take photos, and we'll film it.
Thank you, Karthik. See, the intention of this conference is to benefit every student, not only Kalakarmati. I used to say there is a relationship between the other institutions also. That's it. Invited every college, every principal, every HOD to attend this conference. See, by having a mutual gain every college to get, it's not for the association for only Kalakarmati, who are aspirant, who are interested in doing good things. Definitely we are welcoming on behalf of Avineda and Kalakarmati College. We have a good resource persons are there. Whenever possibility is there, wherever possibility is there, definitely these people will help you to have a wonderful, colorful life ahead. See, as Karthik rightly said, usually students are thinking that when they come to farm is how many years course? But people are thinking that it is 5 years course. Actually, you are very sincere up to 5th year. My experience, journey. And coming to 6th year, I don't know what happened. When they go to regularly hospital, they want to go intermediate, they want to be inside. How Likita showed the recipe. 6 cups she kept. I observed what? 6 cups is nothing but the 6 years of your family journey. Understood? That if you read any cup you miss, outcome will not be there. I hope definitely who are serious about. That's why I asked all the principals, sir, whoever see very serious about the conference, you said 10 students only. I don't want 100 students from each. I don't have the big hall also. So many principals, we want to say it's 100 students. I don't have that much capacity. Who are very sincere to listen morning, 8 lectures power back. So many principals asked, how can you complete by 4:30? Now you see your time. See, definitely with the support of all, we can do less. It's again the credit goes to our beloved chairman Alesham sir and Varun sir, and with the support of Avineda and very good people here, speakers are there every time, bringing very nice people to introduce our family students as well as the B Pharmacy students. So again, wholeheartedly sir, we are very much thankful. You are spending your valuable time. Our relation, you are now Kalakarmati family. Pharmacy family, it should be continuous. Thanks a lot. Once again, I am very much thankful to all the students from outside as well as the TPCP family and all the principal, all the HODs as well as the faculty members from other institutions, our institution, medical college as well as the Medicare hospital from my bottom of heart. I am very much thankful for the grand success of this program. More than 1,700 students, all the people had food. We are lucky that we are part of that. It is 1,300. It is more than 1,700 people took the lunch of medical. Everyone, even patients also did the lunch here. Thanks to Varun and Malaysia sir providing this opportunity to serve all people. Thanks a lot. And felicitation is due on the dais speakers. Likita is very famous. Not only this, everywhere is famous only. See, she's not like Likita. You see the previous dance I told. She is Shruti. Instagram you search daily some. How you could manage these things? You learn from the Shruti, not from Likita. See, daily I open. I have the habit of morning I'll see all the things. First see I will Shruti only. Something different. See, the time management you should learn from your mentor, that is Shruti only. I have a little this thing about Gitanjali. And thanks for coming. And also on the dais, Murli also one more family added. Definitely in handling will help uplift the profession. Thanks to each and every one. Whenever conference is like that, we have to celebrate in this grand way. Okay? Thank you.
I request chairman and co-chairman of the session to felicitate Dr. Likita Tarituri.
Okay, ma'am. Madam.
Now I would like to call Dr. V.V. Gitanjali Madam to receive the felicitation. I request chairman and co-chairman of the session to join the felicitation.
Largely just ring పెట్టింది కదా సార్ స్క్రీన్
Now I would like to call Dr. S. Balamuri Mohan sir to receive the felicitation. I request our co-chairman and trainees of the session to join the felicitation.
One second, sir.
I request Praveen sir to receive the felicitation and I request all the dignitaries to felicitate Praveen sir.
Together.
Then I request the members of the organizing committee to come on to the dais. Organizing committee.
Hello, all the organizing committee members and the speakers here, please come onto the dais. We'll have a group photo. All the organizing committee members, come in. My staff, organizing committee. Please come on. Madam, make it run. We'll have a group photo. Some of the students better ask them to come, please push that side. Boys, please come on to the dais. They have done a wonderful job. Now give a standing ovation to on the dais, not for us, for all the speakers spending their value. Give big applause.
One second.
Sir, Anna Apan. Wait. Aishana. Okay.
Once again, thanks a lot to each and every one.
Thank you all for being here. Let's make this TPCP International Clinical Pharmacy a memorable and impactful.
Is that funny?